Okay, I think we're ready to start. So good morning, everybody, and welcome to the Nottinghamshire Healthcare Board of Directors meeting. My name is Paul Devlin. I'm the Trust Chair. You're very welcome to be joining us, and just to say that we are in a hybrid board mode today. So some colleagues are on virtual connection with us, but this is one of those, it's felt like quite rare opportunities for us to safely meet in person as well. We are in a well ventilated space. We are socially distanced around the table, and it's really good opportunity for us to meet in public. There are some colleagues from around the Trust who are with us as well today. So at the start of our meetings, we always begin to frame our conversations during the meeting to hear from people who have used our services. And I'm really pleased to welcome Dougal to join us at the board meeting. And Dougal's going to talk about the experience of him and his family, and indeed his father's end-of-life care with our hospice. So Dougal, if I could invite you just to tell us a little about your experience, and then hopefully we can have a little conversation as we get going. So if you'd like to unmute yourself, and over to you, Dougal. Still muted. Try one more time.
Can you hear me now, Paul?
Yes, we can, Dougal. Thank you.
Fantastic. Good morning, folks. Please bear with me. I'm not an expert at this, and I have a degree of autism, which doesn't really help. But I want to give you a little bit of context about myself and my father and where we was coming from before we arrived at John Eastwood Hospice. I've spent what feels like decades battling with the local NHS management and social services, trying to get an appropriate level of care for my dad and for my wife. And it is a constant and never-ending battle. Dad was at his wit's end, and we'd tried every single thing that you could think of, social services, the King's Mill, absolutely everything. The only thing that we hadn't tried was a hospice. And I think because of my age and because of my experiences around hospices back in the 70s, I didn't really think that would be an appropriate place for my dad to go. But we was incredibly fortunate that one of the nurses from the hospice came to visit us in his home and had a talk about what they could do. And she took one look at the pair of us and said we both needed a little bit of temporary respite. And it was quite a tearful moment, because she was the first person to actually acknowledge just how far we'd deteriorated down the line, how desperate we were for any form of support or care. And she was very honest with us. She told us about the waiting list and how things worked. But strangely enough, within a couple of days, we got a phone call back from John Eastwood Hospice, who asked if I could get my dad down quite urgently because they'd just had a vacancy open up. So I pulled a few strings and we got Dad down there, and it was just before Christmas. We expected Dad just to be in for maybe a week, maybe 2 weeks, so we could get him back home and I could carry on with my caring role and pay for external carers. I think Dad was in the hospice for maybe 24, 48 hours before I had a conversation with one of the nurses there that they was a little bit concerned about his state of mental health. And I personally couldn't see it. I didn't understand it, because when we brought Dad in, when his medication was changed, yes, there was a change in his mental health, but in general, he could have a joke, he could have a conversation, he could make his own decisions. So for such a big change to happen so quickly with no major event attached to it, I didn't really understand, and it sort of set those alarm bells off in my own head. I am a teacher, I'm a biologist, and I've always said when I've been talking to the NHS that, you know, a little bit of knowledge, it can be quite dangerous, because I don't fully understand what the doctors are explaining to me, but I know enough to ask certain questions. So I think my sensitivity was probably heightened in the build up to Christmas. But it was quite clear almost instantly from the conversations with the different nurses and the different doctors that the period around Christmas was going to be all about my dad. It was about keeping him happy, keeping him safe. They put in different changes. They'd assessed him for falls risk, so they'd put him into a bed where he could be observed. And they really did make it about him, to the point where he had Christmas hampers, you know, he was surrounded in Christmas hampers, and we had nobody that we could give them to. He couldn't eat them. And the nurses, you know, that they had a huge pile of Christmas hampers where patients had passed them on to the nurses. So whilst nobody ever wants to go through that at Christmas time, it couldn't have been any better. All of the support, all of the care was to make sure that I had as little stress and Dad had maximum support for that period of time. As we came out of Christmas, that's when I started to see the specialist doctors, and they started to explain to me what had happened and why it was such a sudden onset. And they worked with me on in terms of the chance to try and get Dad into a home, which we was quite happy to move forward with. And each week, because of COVID, the homes were full, or the ones that had become vacant had suddenly had a COVID assessment, and it got to the point where we was desperate just to find a place for Dad to stay. And during that time, Dad also developed COVID. But the level, even though I couldn't see him, the level of care and the level of information, the level of support that I got was phenomenal. At no time was I any more concerned. You know, I think I had a natural level of concern, but it wasn't overexcited by a lack of information or not being able to see Dad. So I think that was absolutely phenomenal. And I'm just conscious of the time, but I think what I want to drive home is it didn't matter whether I spoke to a cleaner, to a doctor, to a nurse, to the Reverend. It had no difference who I spoke to. Every single member of staff was utterly supportive, was very genuine in the level of help that they wanted to provide, and had an appropriate level of concern both for myself and for my dad. And for me to say that, you know, it was an utterly remarkable time. Nobody wants to go through it. Nobody wants their dad to pass away during it, but it could not have been any more supportive or better than what we received. And I think my final comment to one of the doctors were, whatever you're doing in terms of management for this unit, please take that and transfer it to Kingsmill. Then we wouldn't have all the issues that we've currently got, because there's always a couple of tweaks people or departments can do to make things better, but I don't think there was in this situation. The nurses showed good, appropriate level of humour. They were very real. They were easy to talk to. And if I went and spoke to a different nurse on a different day, they didn't tell me something different. Everything was congruent from beginning to the end. So whilst it was a traumatic experience, I see today, and I know my dad would see today, as a reason to celebrate something that really was genuinely supportive and helpful, and had, was incredibly kind of everybody at an amazingly stressful period of time. So I really wanted to take this opportunity to thank everybody for the work that they're doing, especially all of the staff in John Eastwood's hospice. It was amazing. My wife's been in there for day visits when day visits were allowed, and she had the same experience. So I think there's a real congruency coming through at every single level of staff within the hospice. So keep up the fantastic work, folks.
Dougal, thank you so much for sharing that really important story with us. And I really do appreciate you taking the time to revisit that, like you say, an incredibly difficult time for you and your family. But you've really eloquently talked about how the team at the hospice helped support what I would term a good death, which is a really important piece. And I also appreciated what you said there about taking the good management lessons and seeing where else they can go. So if it's okay with you, I'd just like to open it up for some comments and or questions from one or two colleagues around the table. Who'd like to start us off? Jan.
Thank you, Paul. So thank you, Dougal. That was very moving, and I also lost my dad during COVID, so I can relate to your story. And I wondered, you said at the beginning that initially it was due to be a visit, a respite visit, but obviously it then extended, and your dad stayed there. And I wondered whether that was something that was discussed with you. I know you couldn't get the care home provision. Was that something that you as a family were happy with? And, was that all done hand in glove with you in terms of planning how your dad's care would take place?
But I think that's a really relevant question, because the level of care was so good at the hospice, we didn't want to leave the hospice. It genuinely was that. However, we also appreciate that resources are in demand, and that at some point that he was going to move into a home, and we wanted to move him into one that other members of the family could access and see Dad, but that was close enough for myself with my demands so that I could get there almost at a drop of a hat. And that was the difficult point. We was quite prepared to make the move, but if you ask me, did I want to make the move? The answer would be no, because I could completely trust what was happening at the hospice. And I knew that if anything went wrong, or if there was an issue, that I would get a call and I'd be able to go and see him in the evening, as long as he wasn't on the experiencing COVID at the time. That was the only time that I couldn't see Dad, was when he actually had COVID.
Great, thanks for that. I'm going to invite Sue Sunderland in, who's on screen as well.
Thanks, Dougal. It was really good to hear about your experiences. I just wondered if you could tell us a little bit more about how you got in touch with the hospice. Was it yourself that ended up chasing it, or was it recommended to you by one of the other contacts you had? Because it sounds like things were getting a bit desperate, and it's whether there could have been an earlier contact made.
It was a little bit by accident. We were in a battle with social services because they'd given Dad a level of care that was actually dangerous, and we'd flagged that up as a cause for concern. But what had happened over the last maybe 6 months or so, we had a respiratory nurse that used to come out and see Dad, and she was really good working with me, and she was very blunt and direct with Dad, which worked really well with Dad. So she had a really nice balance for both of us. And we got to the stage where she said to us, the only thing we can do for him is provide him with oxygen. And if oxygen isn't suitable, then we would have to give him we would have to consider end of life care. And it was at that point she managed to contact the nurse that came to see him for the respite care, that they were talking to each other behind the scenes. So I think in spite of the low level of social services and the low level of care from King's Mill, there was people working with the community that was coming into Dad's home that were talking to each other, and they bridged that gap and made sure everything went smoothly. Could it have been done any earlier? I think if we took away everything that was happening from social services, I think the timing was actually about right, because nobody wants to approach that end of life care too soon. With everything that was going on with social services, I think if any of the nurses had been in during that time, they would have picked up on things going dramatically wrong, and then again would have taken the shortcut to put things in place. So I don't think it was ideal, but I don't think realistically from the respiratory side or from the hospice side, anything else could have been done any differently.
Great, thanks for that, Dougal, and really hear what you're saying there about the experience of needing all the different services to be able to work together, just to make things move as smoothly as possible. Okay, just to round things up, John, can I just invite you to reflect on that as Chief Exec?
Yeah, thanks, Paul. John Bruin, Chief Executive. Dougal, thanks ever so much for sharing your story and your family's story. It's really powerful, and whilst it's really heartening to hear that we do have services that do what they're meant to do and to serve people well, I think our task as a board is to pick up your nuggets that we need to be able to clone it, don't we? So that, because we run many other services, perhaps not quite so well, shall we say, because we're always striving to improve and to be better. So I think for us as a board, there's a conversation about how we can distill out some of the key messages that we can learn from John Eastwood, because it's a really emotionally charged and difficult environment to do well. So it's always gratifying to have such great feedback, but our task is to make sure that we can spread that wider across the trust. So thank you for taking the time to help share your story, and on behalf of the board, wish you and your family all the very best for the future. Thank you very much.
Yeah, absolutely. And Dougal, we will hold you in our minds throughout the rest of our meetings today, because there are some really helpful, gentle challenges that you've given us, which is really helpful for us. I really appreciate you saying that you thought that your dad would reflect positively about this too.
Yeah. He told me on more than one occasion he felt safe and he knew what was happening for most of the time. So thank you. That's
great. Well, look, Dougal, we'll let you get back to the rest of your day. Thank you so much for taking the time to join us and for sharing such a powerful story with us. It's very, very much appreciated. Thank
you very much, folks. Have a good day.
Thank you.
Bye-bye.
Great. It's always It's always really powerful hearing patient experiences, but that one I think particularly I know will have touched many of us around the table today. So if we can go to our routine business, please, colleagues. Just to say there are a few different faces who are with us. Welcome to Chris Ashwell, who has joined us, stepping in on behalf of Julie Atwell. So thanks for Atwood. I'll get there in the end. Atfield. Welcome, Chris. Good to see you, and you're with us on screen. We have a number of other colleagues who are in the room with us. Just to particularly draw attention to welcome Rebecca Allen, who's with us on her second day as Deputy Director of Corporate Services. Welcome to you, Rebecca. And then in terms of apologies, we've had apologies from Julie, who I've mentioned already, and also from Manjit Darby. And I think in terms of board members, those are all the ones that we've got. Thank you. That's great. Can I ask colleagues if there are any declarations of interest in relation to today's agenda in the public part, please? Nope, that's good to know. And if we move to item 5, questions received from the public, we have had a question from a member of staff who's over the last couple of years asked a number of questions and on a similar theme, and has queried when the Trust will be reviewing the policy relating to masks in the Trust. So if I can, I think, invite Anne-Maria, if you want to introduce yourself and give a response to that for us, please.
Yeah. Hello, my name is Anne-Maria Newham. I'm the Executive Director of Nursing AHPs and Quality. Yes, this gentleman has sent in quite a few questions in the past, and I have a similar answer, I'm afraid. So on the 1st of June, the national guidance came down that we were able to remove masks. And we looked at that guidance and did a risk assessment of both staff and patients at the time. And we introduced no masks from the 20th of June for anyone in non-clinical areas, plus areas that we felt weren't high risk for our patients and vulnerable patients. So that was on the 20th of June. Unfortunately, at that point, there was a rise in outbreaks, both for ourselves and nationally. And on the 7th of July, we received national guidance to say that we needed to reintroduce masks both in clinical and non-clinical areas. I actually, at that point of receiving that guidance, I think it's really important to say, is I reached out to all of the trusts in the system, plus our mental health trusts in the region, to ask what they had done and how they had gone about doing it, because I realised it was a big step for us to go back into masks after we'd taken them away. And I don't think it's something that we should do lightly, because it's a difficult thing for staff to do one thing and then have to revert back. So at that point, Sherwood Forest hospitals had gone back into masks already, 4 days previous to that. So had Nottingham University hospitals as well, and all of the region's mental health trusts had gone back into masks actually on the 7th of July as the guidance came back in. So the guidance was issued on the 7th, and on the 8th we put it out into communications that we needed to go back into masks. This is national guidance that we follow. So that's how it all came about. As soon as we get guidance again to say that we can go to risk assessment again and we can go into no masks in certain areas, we will absolutely take that guidance, look at the implications for us, do the risk assessments, and we will make sure that we do that for our trust. But we have to follow national guidance. We cannot decide as a singular trust to do something different to what all of our trusts around us are doing.
That's great. It's a really, really clear response for us, Anne-Maria, and just that importance of us following the guidance, but also doing thorough risk assessments at any point that there are changes. We all want to make sure that we can get to being mask-free as quickly as we possibly can, but we need to maintain the safety of our clinical areas at all costs. So thank you very much for that. Okay, folks, if we can move on to item 6, which is the minutes of our last meeting from last month. And I'll just pause. Can you just give me an indication if we consent to receive these as an accurate record, please? Yep, I'm getting nods. Thank you very much. And in terms of matters arising and the action log, there was only one item on the action log which has been moved along and completed. So I'll see if there's anything else anybody wanted to pick up as matters arising. Don't think there are. In which case we'll move on to item 8, which is my report. Just a couple of things that I want to draw attention to, if I may. First off, over the last couple of meetings, the board will be aware that I've been referencing spending quite a lot of time being involved in the recruitment of a substantive chief executive to be the substantive replacement for John. And I'm delighted that I can now speak publicly about the fact that we have made an appointment. Really pleased that Ifti Majid is joining us. We hope that is going to be before the end of the calendar year, which would be fantastic. Ifti is well known in our region. He's currently Chief Executive at Derbyshire Healthcare. And we're absolutely delighted that Ifti is going to be joining us and very much look forward to working with him. I think it's important just to say there will be a period between John leaving and Ifti starting, and we're extremely pleased that Anne-Maria has agreed to step in as the interim chief executive. So from the beginning of September until Ifti starts, Anne-Maria will be the interim chief executive. And I know that she has got the full support not only of her executive colleagues, but also the non-executive team here. And we're looking forward to you stepping into that role, Anne-Maria. And I think an important one to note as well, that with Anne-Maria stepping into that space, it was very important that we looked at who was going to be an interim into the Director of Nursing role. And I'm delighted that Tabitha Darman is going to be taking that role on, and look forward to welcoming Tabitha around the board table for that interim period as well. I think it's a really strong message about some of the succession planning that we've been working to as a board over the last particularly year or so, and it feels like that gives us a lot of good continuity, which is very important. The only other thing that I wanted to mention was having joined a good range of staff and other colleagues at the weekend for the Nottingham Pride March, which was it was great to be part of. There was a very long march because there were a lot of people there, and we also had a couple of stalls in the as part of the Pride event. And I spoke with a colleague yesterday who was saying that the stalls had been really well attended as well. And I know lots of our staff put time into staffing those stalls during the day as well. It's always good to be involved in something so positive. So I'll just pause to see if there's anything anybody wants to pick out from my report. Trevor.
Yeah, Trevor, non-exec. I note in the report that you're getting pulled into more and more system-wide involvement. I was just interested to see what your confidence level is of that growing and how that's developing.
Thanks, Trevor. Really good question. I think that as a trust, we are absolutely committed to our working with our system colleagues. And that means that we need to keep on assessing who is being taken into what bits. And certainly there's a challenge that we all face about how our time is being split. So it's important we're able to hold on to our responsibilities for this organisation. However, we're all committed to being a good collaborative partner, and that's why there are some pieces that I'm picking up. I think there's one piece that I'm picking up specifically during the interim period, where John's been chairing a group that I will take over. I think it's also important, it's an opportunity to say that we've been looking too at some new opportunities to involve non-executive directors in different pieces. So some of that comes about from chairs of some of the committees being able to meet with their peers, and with non-executive directors from the Integrated Care Board that oversees things. But also we've been asked as providers to see if we wanted to nominate any non-executives collectively to be part of some of the system committees. And I'm really pleased to say that Nigel is going to be on the Finance and Performance Committee of the Integrated Care Board. He's not there as a representative of us. He's there to bring provider perspective for all of the providers, and really pleased that we're able to do that. And Trevor will also be looking very closely at how we ensure that information comes back from all of these different pieces of connectivity, and executive directors are well linked in with their peers too. Thanks for the question.
Thank you, Chair.
Okay, in which case let's move on to item 9, Chief Executive Report. John, over to you.
Thanks, Paul. Morning, everybody. John Brown, Chief Executive. You won't be surprised to hear this is my last report to the board. So just to cover off a few things in a bit more detail, because I'll take the report as read. Update on page 17, where we are with the CQC. So Anne-Marie may want to expand on this a little bit, but we've had some contacts with the local lead with regard to where our reports are. You'll be aware that we've had the first one for forensic services from the inspection back in February, but some pleasing news that they're not far from being with us. I don't know, Anne-Marie, you spoke to the lead inspector the other week when I was away. Yeah, so I spoke to Craig Howarth, who is our lead inspector, on the 26th of July in the morning. It was a good conversation, actually, because I wasn't sure how he would greet me wanting to know what's going on, but actually he was really good, and he did make a huge apology to say that he realised that they had inspected us quite some time ago. In fact, it started on the 3rd of February, went through till May, and we've still not seen the reports. But he was really apologetic. He said that it was circumstances beyond his control. He'd got some senior sickness that had meant that the reports hadn't been written in a timely way. So what he said is that he was expecting them to come out in the next 2 to 3 weeks, that we would then do our factual accuracy, and then they would be published as one. Now, what we were always told is that they would all come out separately, but what he said is that they would come all together. They would be separate reports, but they will come at the same time, and they will be published at the same time as well. I did inquire as well about Brampton Hospital being inspected, because again we had been kind of like given inference that it would be inspected in the summer, and he said he thought that would be soon was the word he used, and that was pretty much it really. He did say that because I know that the board are aware that we did get a notice around the dormitories. We responded on the 14th of June to that, and I said that we hadn't had anything, and we'd seen nothing to indicate whether or not they were happy with our response to that. But he did say that was a totally separate team to the one that are doing the other reports, and that we would expect to hear from them very soon as well. And that's it really. Thank you. There's a couple of questions.
Yeah, let's take a couple of questions. Trevor first, and then Karen.
Yeah. Trevor, I'm a non-exec director. I'm just intrigued at the time delay for writing the report relative to giving us the assessment. Do you have to wait until the reports are formally issued, so they won't give us an indication or a formality?
No. They gave us verbal feedback at the time, and that was pretty good, but you can never rely upon the verbal feedback being the same as what's then written in the report, because often it can look quite different.
Wow.
So and we've fallen foul of that before, where the verbal, we've taken it and then actually it looks really different in the formal written report that is published. But yeah, so there's nothing we can do until we actually see it.
Wow. Thank you. Carolyn?
Yeah, Amber, just a clarification. I think I might. When we get reports, and obviously we don't know what we'll get, but we're hoping that they will be improved position. But our overall trust position won't change until we've got the Brampton inspection done.
They will change it.
Oh, they will.
They will change it, and then it will change again once we've had Brampton.
Okay.
So we'll have a rating based on this inspection, and whatever that is. And as you say, let's hope that we get an improved rating score. That will be a published one. That will be something that we put up as a poster. And then when they do Brampton, whenever that is, that we will get a new rating score.
And will Brampton's existing rating be included in that?
Yes.
Yeah.
Yes. That's what will make up the kind of like algorithm that they use to give us the rating score.
Thank you.
Alison?
Thank you. Alison Wild, Executive Director of Finance and Estates. Just to highlight to board, given the timelines that you've just told us, Anne-Maria, is that external audit have not yet issued our value for money opinion, and given the lack of clarity on exact dates, I am assuming at this point that we will need to lay our accounts before Parliament in September with the old scoring and value for money opinion. I just think it's important the board are cited on that.
I think realistically, we are sitting on the 2nd of August today. I think that even if we got it at the end of this week, just say we've still got 10 days factual accuracy, and then we've still got to wait for them to come back and say yes, they're happy with that, and then publish. So we're looking at least 4 to 6 weeks, even if we got it this week.
Yeah, so I think we lay our accounts before Parliament on the old opinion. I'll liaise with our external auditors. Thank you.
Thanks. That's a really important point for us to log there. Nigel.
Nigel Smith, non-executive director. I was going to raise the same point as Alison, that we have got a bit stuck with that value for money opinion. So this delay, it is now, I think delay is now the right word, isn't it? Has had some consequences for us. I just wondered, Anne-Marie, whether he should have rung you, really, rather than the other way around. That's a courtesy. It just seemed to me to be quite extraordinary.
Well,
that they couldn't, first of all, courtesy to call you. Secondly, when you'd asked the question, had a reasonably firm timeline rather than saying soon. I find that really surprising.
Anne-Maria and John will take care in the public environment we're in.
And we've been living and working in extraordinary times, haven't we? And to be fair to the CQC, they've had as many challenges around staffing as we have, and it's unfortunate what's happened, as Trevor identified, receiving scores from inspections over 6 months ago. You could argue isn't especially helpful, really, because time moves on and hopefully certs improve. But I think we just have to accept it. You know, it's not ideal. It would have been great if it could have been sooner. If there have been improvements, I'm a bit disappointed that I'll be gone. But if it's still gone to pot, then I'm not. But
we plan to send it to you in the post. That's absolutely fine.
I think it is what it is, and I think the important thing is that hopefully, well, we've already shown, as we'll hear about later, some really tremendous improvements in the forensic division, and I'm optimistic that some of the individual ratings in the services will improve. Whether we'll get sufficient improvement to change the overall trust position, I think it's a bit more difficult to judge. But I
just wanted to add. What happens when you're inspected is if there's any concern, high-level concern there and then, they have to ring you on the day. And I was contacted twice around, number one was the dormitories, to ask what the plan around the dormitories were, and also around some executive files as well. So they have to tell you on the day if there's any high level of concern. So when I spoke to Craig last week, I asked him whether or not there was anything else that he should have told us at the time, and he said no.
Okay, thank you. That's helpful. Sue Sunderland, I think, will take us to the last comment on this piece. Sue?
Yeah, it was just to provide a bit of reassurance on the external audit piece, because talking to the external auditors, they did have a plan B, and on the basis of the work that they've done, there won't be a negative impact of us not actually having received the CQC. They were just hoping they could have updated things in light of that, but actually I don't think it causes us any problems at all from that perspective, the delay.
Great, thanks for that, Sue. So John, should we come back to you?
Yeah, so thank you. So well, it's the next item down actually around system, because there's some bullet points there which won't go through, but you'll all be aware of how challenged the wider system has been, not just in Nottinghamshire but nationally too. I'd only been away one day last week, and a critical incident was declared in the Not system. So I don't know whether Anne-Marie, you wanted to back to you again just to provide a very brief summary about what that entailed.
Yeah, and I'd also like to remind Dr. Bruin that the last time he took leave, the CQC turned up for a well-led inspection as well. So so last week, as he took leave, on the Tuesday, myself and Becky got called to an emergency CEO call to be declared a critical incident across the whole system. It was mainly to do with Sherwood hospitals and Queen's Medical Centre struggling with a backlog of patients within the emergency departments, and also ambulance waits, which of course everybody's been aware of over the last 6 months has been really a difficult position. So the critical incident was called because of the amount of patients that were waiting, and also really actually a lot of hours being spent trying to sort some patients. And on that point on the Tuesday, they actually had a patient that had been waiting 40 hours in A&E, and it was an elderly gentleman. So the critical incident was called. What that means is that when you go into critical incident mode, then you are sort of like a heightened levels where you have to report through into the national team, and also you're asking for support from the region as well. That's what it actually means. But it did require myself and Becky to attend 2 meetings per day to try and support. Now, I will let Becky say, but she pulled out all the stops. Absolutely fantastic. If you ever need anybody on an emergency meeting, call Becky's the person, because she was able to do an awful lot to help them out as well. But I'll let you describe what you did, because it was really phenomenal.
Thank you, Anne-Marie. So Becky Sutton, Executive Director of Community Health Services. So as Anne-Marie said, it's been under a lot of pressure, and I think what the critical incident also allows is to do some things out of the normal sort of parameters. To be fair, for community services, we did all the things we could do. It did involve some derogations of stepping down some of our planned services, which we've done through various times, and I'll get onto later in the IPR in terms of the effect of that. But actually, I think what we were able to do was to deploy some really good resource in our urgent care response team that you've heard me talk about at board a number of times. And actually on Friday, delighted that there was 20 patients they avoided an admission. So often in this sort of situation, we focus on getting people out for discharge and complex people. And whilst we did all of that as well and saw who we could pull out and get home and get to other places, actually, if you can stop the flow in the front door and stop patients being admitted in the first place, that actually has a much bigger effect and a much quicker effect, as I remind our colleagues in the system quite often. So I think, it really shows community services can play a hugely important part in this. I think, as we heard earlier, and I think the patient story reminds us, there's so much more we can do around how we integrate our services, how we make it easy for people to use. And some of the really exciting stuff about urgent care responses, it's one single number for the whole of Nottinghamshire. So that includes city care services, social care, and I think it's about easy access. So there was a number of things we did. We as I say, look to fill beds, but actually more importantly, look to try and get people home. And they're the things that are really going to sustain and make a difference, and supporting social care in terms of what health can play in terms of those mixed packages, and how we get people home. But thank you, Anne-Marie. It was, I would like to say it got stepped down yesterday as a critical incident. However, what we've decided to do is keep some of our derogations in place this week, just to aid that, so that we don't end up back in a similar situation next week.
I do think it's worth the board knowing that what we also derogated, and like I said, it's extreme circumstances, we would never normally do this, but what we also derogated is what the story you heard today was, the John Eastwood Hospice beds. So we opened up the beds to allow admissions that were non-palliative, non-end of life. So that's quite a big step to do, but that's what Becky did for both Bassett Law and John Eastwood Hospice.
Thanks. John?
Okay, yeah, thank you.
Sorry, Fiona, let me just bring Fiona in with a comment. Fiona, please.
Yes, it's just a comment, just to say just how amazing all of that has been to hear, and the impact on our patients, the things that we have done to make a huge difference under pressure, already under pressure service across the board, across Nottinghamshire. So I just wanted to say publicly, just well done. It's been absolutely brilliant to hear this great work, and how we can all really come together and help support across the system, and I'm glad it's been aired in a public setting as well. So well done, thank you.
Thanks, Fiona. John?
Thank you. A couple of things from the divisions on page 18. I think it's important to note under IAPT, the Improving Access Psychological Therapies, the very difficult decision to withdraw from the provision of this service, which will transition at the end of March next year. At the minute, we're in open dialogue with staff and what was the CCG people now working in the ICB, the Integrated Care Board teams, about how that will be managed over the intervening period before we go to a formal organisational change. So that's IAPT. On the next page.
Oh, just one, Paddy.
Sorry, John, I just wanted, Paddy Tipping, non-executive director. Just wanted to take you back to the ICS and the final bullet point there, finalising plans, financial plans for 22-23. I mean, we're into the second quarter of the financial year. The system's in deficit, and I just wonder how those discussions are going, because it makes planning very difficult, I think.
Yeah, thanks, Paddy. I referred to my previous comment of extraordinary times. As you know, the last 2 or 3 years, 2 years, 3 years, we've not finalised the annual financial planning for all organisations until the financial year has started, and that would have been heresy 3 or 4 years ago. It's all done and dusted by February, March at a push. And these are the challenges that Alison and her team and the teams within the system are having to manage, that the amounts of resource being allocated for services, the additional bits for COVID, the withdrawal of COVID funding, etc., make it really tricky. I don't know whether, Alison, you want to say anything?
Yeah, thanks, John. Alison Wild, Exec Director of Finance and Estates. Thank you for the question, Paddy. It is really challenging, and John's absolutely right. We would normally have submitted plans a long time from now. We've resubmitted plans last month. As a system, we are still in deficit, and as the Midlands region, we add up to 50% of the national deficit, so we are on the national radar. So in terms of our revenue plans, we are they are submitted. There are still challenges and asks of the regional and national teams to better those plans wherever we can. And there is also a slight challenge for us that if we don't hit our revenue plans, they're talking about reducing capital expenditure to help fund that. So there's still not finally set in stone. I think we've got a lot of work to do as a system to get to where we need to be on revenue and capital, and support each other in a different way. but it is challenging. But just to confirm, the revenue plans are now in place, and ask that we do more if possible.
Paddy, do you just want to respond?
Yes, that's really helpful, and I accept it's challenging, and I understand heresies. But what's the timetable, John, for resolving this? Because we're now 4 months into the financial year. I'd be much more comfortable if I knew what the finishing line was.
Yeah, thanks, Barry. I think we all would. I don't think I can answer that because I don't think anybody knows. That without getting into sort of politics of things, and we're all aware, aren't we, of the turbulence, shall we say, nationally, and that plays down through the Department of Health and through the national regional teams. And I think it's really difficult to predict how it's going to land. In terms of, for example, the various things we're hearing about, taxation policy, whether there'll be yet another new Secretary of State and what their take on the NHS, a hawk or a dove or a bit of both. I think it's really difficult to predict, and I think the only thing I could say is going to be really rocky, this year and into next, and difficult to call. I mean, so it's be open to us as to our utmost priority has got to be to our patients and service users, and as a mental health, learning disability and community trust, we make sure that we've got solid financial foundations and that we use our money well. And a second order is to the system. I don't think the system is mature enough where we can say we trust everybody in the system to look after our money as well as we would. But that's what we're working towards, but there's a long way to go.
I think both John and Alison will have heard the challenge in our public board and the concern that we've expressed here, and be able to take that into any of the discussions that you're having with colleagues across the system. John, shall we move on?
Thanks. So I just wanted to, bottom of page 19, sort of re-emphasise the conversation we just had around community health services, really, is that the point about the urgent care team 30% above activity that was predicted and 99% achievement of the 2 hours, and to draw that into a wider, okay, that's very interesting, John, but so what? But as Becky described, from a strategic position, it's a huge opportunity for this trust to develop its collaborative and integrative working, particularly with community services, into the emerging primary care networks, into primary care, which is on its knees, and general practices, which would really benefit from our infrastructural support. And there's huge amounts that we can do that will impact on the really flashing red acute sector, but that we've got to do it before they get to the acute. It's the argument about the only way we can sort out ambulance delays is to look at how we can sort out ambulance delays is wasted energy. We've got to do it before. I know we've got a strategy paper coming up later, but I'd really encourage us to look at that, how we can continue to really push that work forward. On the next page, just to focus on briefly on the forensic division's work on reducing restrictive practice. It's a huge piece of work. It's one of the scariest things, if you like, that our people do in terms of restricting civil liberties. And there's been some huge progress in both our monitoring of, but training and support to enable staff to continue to reduce the amount of restrictive practice we use. Not just within the forensic division, but that's where some of the most stringent practices. To highlight that good practice, and then there's a whole reportage under the communications summary. I just wanted to pick out a couple of things at the bottom of page 20. The visit of Nadia Whitton to our transgender health service at the beginning of July was really well received, and Nadia cropped up again at a conference that we ran, which isn't in the paper actually. We'd flagged it before, titled a trauma conference, which was hosted by our Centre for Trauma Resilience and Growth, Steve Regal's team. And it's a very specialised service, which is doing some amazing work for some extremely traumatised and people who've experienced extreme psychological, physical trauma. And it was, the opening address was from Terry Waite, previous envoy to the Archbishop of Canterbury some years ago, told his story of being held hostage for a number of years, and how he survived that. And again, something for me to pick up as a sort of one of the last few things to do is to make sure that we continue to support that, because it's not formally commissioned service, but it's doing some such valuable work for people, and the ability of those people that experience this to describe that their testimony at that conference was really quite moving. And then at the end of the paper, as ever, there's an increasing list of staff who've been nominated and awarded various awards for brilliant work. Just wanted to point people to that. And then finally, for me, back up to the executive summary. I've not gone into anything too executive or summary. This is a thank you, but it's I wanted to publicly thank some people who often behind the scenes do miraculous work, and there's a list of people there who I will name, who've supported me specifically since my sojourn with the trust began in 1991. Claire Croucher was my secretary when I was consultant at Rushcliffe. She worked in the outpatient department at Queen's. Chris Barks was receptionist and secretary at George Road in Rushcliffe, as was Jane Litherland. As clinical director, Nikki Dobson and Grace Rowe tolerated me, my disorganisation, my inability to manage my diaries, and my appalling sense of humour. And Claire Stagg, and then Grace Rowe came back for more. And then finally Lauren West. I want to thank you all personally for helping support me in my endeavours. Like I say, that the administration is the foundation that holds our services together, really, and is often unrecognised. So I wanted to say a huge thank you for all that you all have done in supporting me over the years. I'll say a little bit more right at the end, but thank you and wish everybody all the best. I will miss you immensely. Thank you, Paul.
Great, thanks very much, John. We will come back to you at the tail end of the public meeting, but as ever, appreciate the thoroughness of your report, which is an important one for us, just to surface key issues that may not be on our other parts of our agenda, and also to acknowledge some of the breadth of what's going on across the trust as a whole. Okay, we can move on then to item 10, the review of partnerships update. Jan, please.
Very much, Paul. Jan Sensier, Executive Director of Partnerships and Strategy. So this paper really sets out we've referred to it several times already this morning, the very complex world that we're now in terms of partnerships. All of that complexity is designed to move us from a point where I think as the NHS we work more in competition with each other to a point where we're working in collaboration with each other. And we've heard some excellent examples already this morning of how that collaboration can really pay dividends for patients and for our staff indeed. What my brief is in the trust is to help the trust to be a good partner in the system. And as I've now completed my 4 months in, we've been kind of taking a step back and reviewing where we are. And what myself and my team decided to do was to really try and map all of that out. And this paper attempts to try and explain. I know when I talk to colleagues sometimes, it can be very confusing. We've got the ICS and the ICB, and it's all acronyms, isn't it? And then we've got the provider collaboratives. Some of those have a regional footprint, some of them have a Nottinghamshire-wide footprint. They involve collaborations with different types of providers. So in the system, we're collaborating with our acute partners, but when we come to the East Midlands, we're collaborating with our mental health trust partners. So that can seem to be confusing. And then we have the place-based partnerships, and there are 4 of those in Nottingham and Nottinghamshire. We have the City, we have South Nottinghamshire, Mid Nottinghamshire and Bassetlaw. And even if we delve deeper beneath the place-based partnerships, you have the primary care networks, which sit beneath those place-based partnerships. So working out how can we be a good partner in the system is quite complex. And we took this paper to our strategy committee because we felt it was really important for us to provide some clarity about what we want our role to be in terms of being a good partner, and to develop a partnership plan for the trust. And so this paper really sets out our intention to work across the summer collaboratively in identifying what should be our partnership plan by mapping the partnerships we currently have in place, identifying what relationships we need to have, how we want those to grow, and both what are we trying to achieve as a system and for our patients, but also what are we trying to achieve as a trust within those partnerships. Some of it as well is about identifying priorities. We've already referred to the time that Paul and John and myself and my team are spending in partnership working. We're by no means the only ones. You know, I think all of the executives work very collaboratively with colleagues across the system in partnership. One danger is that we could spend an awful lot of our time in meetings and not actually achieve a great deal. So the point of this partnership plan is to try and get us to a point where we're really clear, we're very consistent. When any of us go out and work in partnership, we know what it is that we're trying to achieve. We know what the ambitions are, and also that we can prioritise our time and not, you know, fill up the 37.5 hours a week with meetings and do nothing, but actually identify which are the crucial things that we need to do and how we need to do them. So we're just bringing this paper at the moment for information more than anything else, Paul. As I say, it's been through strategy committee. It is very much a heads up. We're working on this through the summer, and what we'll do in the autumn is to bring back the results of that and to bring back a partnership plan for approval.
Great, thanks very much. I've got a few comments. I'm going to take Fiona first and then come to Paddy and then back to Sue. So Fiona, please.
Sorry, I don't have a comment. It's not me. I think it's Susan S.
Apologies.
It's okay.
That's your comment. Thanks very much. This is the challenge of the hybrid piece. Paddy, let me come to you then.
So Paddy Tipping, non-executive director. I mean, this is a really important piece of work because things are changing dramatically, and Jan, the focus is on the health service, but we need to think about other partners too. I mean, I suspect that there will be a devolution deal announcement within the next few weeks, which is causing major concern for local authority partners. We all know that the local authority financial system, particularly locally, is really difficult. And again, one of the things I'd be very keen to focus on is the work that the Trust does, and I think we need to develop with the third and voluntary sector. So I'd be keen to see all those things in the report. But I think one of the things that will be really interesting is, as a result of this work, to see what partners want of us. I mean, this is a two-way street, isn't it? We want to know where we're going, but we need to reflect, I think, on what people's aspirations are of us. And talking around the system, I think there is some confusion about that. and a lack of understanding of where we stand and what we stand for. So hopefully that will be a focus too.
I think they're all incredibly good points, Paddy, and just to touch on a couple of things. Devolution, yes, very, very much on our radar. And in fact, I had a really good conversation with Will Morledge, who's the chief exec of the local enterprise partnership, D2N2, the other day, and we were identifying some areas. There's some stuff already going on into the deal around skills and how we can, using our anchor institution status work and get involved in that, I think is one area, but also talking to Will about what should we be pushing for. We'll have an initial devolution deal, but what should health and care be pushing for in terms of future deals and the second round? So yeah, absolutely. And in terms of local authorities, obviously Nottinghamshire County Council, and we'll have a new chief executive, Adrian Smith, taking up post when Anthony leaves in the autumn. And we work really closely with Mel Barrett through the Nottingham City place-based partnership. So you're absolutely right. We need to keep really close to both of those. And on the voluntary and community sector, one of the reasons why we want to map is I'm aware. So both Becky's division and the mental health division, I think, do some really great work with the voluntary and community sector and already do quite a lot of subcontracting and do quite a lot of. But I don't think we've got an overall picture in our minds of that work. And I don't think we have as a system. The County Council have just refreshed their compact with the VCS. And one of the things that I've been talking to them about is, do we need a system-wide compact? And also a system-wide commissioning strategy for the VCS, or is that something we're better off doing in place? And these are the kind of questions we want to tease out over the next couple of months. So yeah, I think they're all really good points, and I wouldn't want anybody to think this is just a health service partnership strategy. You're absolutely right. We need to look a lot broader than that. Thanks, Paddy.
No, thank you.
Thanks, Jan. Sue S, please.
Thanks, Jan. I think it's a really good proposal. I'm glad to see that we're looking at the partnerships we're in and developing so thoroughly. I just wondered, I think it's implicitly covered by the scope, but whether we needed to be a bit more explicit about making sure that we are assessing the impacts that these partnerships are having in terms of are they actually delivering against the objectives we set up in the first place. And also going back to your reference to the priorities and capacity constraints, I think perhaps not to be afraid of identifying some partnerships that aren't working and aren't delivering, that we might want to stop or refocus to make sure that we're actually making best use of the limited resources we've got available. So just a couple of points to suggest further.
Very helpful, thank you, Sue. And yeah, I think that's partly what we want to do is to be that. And I think the board can help us, and the strategy committee can help us when we present back the results. Is to I don't want to say ruthless, but to be able to prioritise and really make the most of our resources. So and the point about evaluating impact is really well made. Thank you.
Great, thanks, Sue.
Yeah, thank you, Sue. Sorry, my voice. Sue Nixon, Exec Director. Paddy very kindly asked my question, so thank you, Paddy. But could I just ask, one of the issues, you've made it very specific that you're not concentrating on stakeholders at this point, but rather partners. I'm also interested to know how you're going to be addressing ensuring we maximise inclusivity, both across communities of interest and also communities of geography.
Yeah, I think that they're both really good points. So I guess one of the things that I want to bring in here, and this is where my role is to bring these things together, is that we've now gained agreement, I believe, John, from the ICB, that John, who chairs the ICB-wide Health Inequalities Group, when John leaves and in the interim, I will take over the chair of that, because we were really keen to keep a very strong interest in that. And I'm meeting with Chris Packham in a couple of weeks' time to really discuss how we can make the most of the work we're doing in the trust on health inequalities, but also at that level, and how we can make sure that health inequalities really plays into our work in partnerships. So I think health inequalities and inclusivity aren't exactly the same thing, but they're very closely aligned. And I think that's kind of the lens that we're going to really try and make sure
that we deliver that. Thank you for being so explicit.
Yeah, that's really good to hear. So, colleagues, we're asked to note and support this work. I'm getting a sense around the table and on the screen that we're very much in support of this jam, and note the timetable that you've set there in terms of the plan as well. So thanks for that. Let's move on to the integrated performance report. Alison, what I suggest is that we start on this, but I think we'll aim to take a break around 11 o'clock anyway. So I suspect we'll need to pause partway through. But over to you, please.
Okay, thank you, Paul. Alison Wild, Exec Director of Finance and Estates. The integrated performance report is presented to board for assurance in terms of our regulatory standards and internal targets, and the data is for Q1 up to the period the 30th of June. Page 38 of the pack refers to our key performance summary, where 8 areas of key concerns in terms of patient care. And just to note that the report is on an exception basis, and I will then hand over to my executive colleagues for the leads in their areas, starting with Anne-Maria Newham and quality.
Yeah, thank you very much, Alison. My name is Anne-Maria Newham, the Executive Director for Nursing, HPs and Quality. I'm taking you to page 33 of the Teams, but also page 2 of the report. So quality oversight is really with regards to safer staffing. I've reported that over the last 6 months, and the trust wards are still experiencing significant low staffing numbers, particularly impacting Brampton Hospital, High Secure Hospital. But I am also introducing something new today, which I've not told the board before, which is the level of restrictive practice across the trust has significantly reduced, with lower levels of prone, secondary and tertiary interventions reported for month 3, which is June for us. So the number of instances of rapid tranquilization usage has also markedly decreased against the long-term average as well. So that's just a really good news story that I've not been able to report before. Happy to take any questions.
Great, thanks very much. And Maria, I'll pause to see if there's any questions people want to bring into this piece. In which case, thanks. Alison, steer us on, please.
Thank you. Now move on to the people and culture section, and so I'll hand you over to Jen Gwyver.
Hi, I'm Jen Gwyver, Executive Director of People and Culture. And so I'll take the report as read, but just pull out some key points. First, as forecast at the last board, sickness during June did increase. We were already feeling it when we met last time. There is a typo on page 34. It didn't increase by 10% over a period of a week. It increased by a percentage. During June, we did get almost up to 9%. So obviously that 7.1% is the average of that period of time, but there were weeks, days where it was significantly higher than that. It does feel like that pressure's easing now, and the daily rate is about 7% again, so we seem to be back down to pre this wave. Lots of work going on, both at service level in terms of attendance management, but also just upping momentum of our staff wellbeing offer across the trust, to hopefully make a positive impact on that metric. Second thing I wanted to highlight was appraisal rate. You'll have heard me at the last couple of boards talk about a data accuracy exercise that we've done. As you can see from that, that's really paid dividends. So 4% increase between May and June, and we're now impressively at 80%, which I think, given what's happened with the COVID wave over the last couple of months, that's really strong performance. We're also working with colleagues across the trust on an engagement piece around what makes a good appraisal. So our quality improvement colleagues are also involved, and also the staff engagement culture team on improving the offer of an appraisal. And I think in summary, focusing on the employee's personal development rather than sort of ticking, yes, you've fulfilled your job description this year, but actually what would make you happy and fulfilled in this coming year. Just to note, training is on an improving trajectory, and that's linked really to be able to have more people in a room, more face-to-face training. And we've got our first, we're reintroducing face-to-face induction from September. So real key opportunity there to set our stall out in terms of what it means to work at Notts Healthcare from day one and weave the values through that. I think it's fair to say that we're not where we need to be yet with the people metrics, and I see this is a long, probably 2 to 5 year project really in terms of making us a great place to work, and the people plan, which is under construction and should come to October board, is what underpins that going forward. Happy to take any questions.
Great, thanks. I'll start with Fiona, please, and then come to Sue and to Trevor as well.
Thank you. Fiona Daniel, Non-Executive Director. Just a couple of questions. I have noted in the paper that we have a sort of a challenge around employee retention. And I know we talked about this before to previous board, but I just wondered where we are in terms of really understanding the data around, you know, who's leaving, where they're leaving from, in terms of exit interviews. Do we have any data around that? So just wanted to know where we have got to around that. And then my second question is connected to appraisals, and it was just more of a curiosity question in terms of helping enhance that number. So that question is around, in terms of on average, how many direct reports on average do people have, and do we think that that probably sometimes could have an impact in terms of how the appraisals are done, in terms of really having the quality appraisals and good conversations aligned to the aspiration that we have, that's more focused on the, you know, what on the how people are doing and their development as opposed to what they've done.
Okay, so taking retention first, I'm probably going to rehearse what I've said a couple of times before, both at people committee and board. I think in the short term, we've got our heads of workforce, who are essentially our people business partners linked to divisions, making sure that we understand the areas of highest turnover and we concentrate our short-term efforts in those areas, and that's through our creating capability changing culture programme. So making sure that the OD team are focused in the areas of greatest needs, and that's not just about turnover, that's about sickness rates, appraisal rates, etc. Sort of medium term, we're running and we don't have good data on exit interviews, and I've said that before, and that's linked to the fact that the ESR system doesn't really allow that a rich collation of data. It's very much a select the options of why you're leaving, and then we rely on managers to do a face-to-face sort of paper-based exit interview. So we're working with our digital colleagues, and it's in the digital plan that's overseen by the digital information group, to create our own bespoke sort of system that allows a bit more, is more positively encourages people to have that conversation at exit interview, which will give us data, but that's probably going to be a year by the time we have something, the amount of data, I guess, to use properly. Then longer term, there's a lot of focus on this nationally. So I heard yesterday that there's NHS England are implementing a retention lead per ICS. So that will be a post that will be going out very shortly. So that's news off the press yesterday. And then back again into the people plan, really, that if we're going to make an impact on our retention figures, Notts Healthcare's got to be a great place to work. We've got to have a learning offer that makes people want to stay. There's a big thing around belonging at Notts Healthcare and our EDI agenda. So I think it's sort of, we can do as much as we can currently, but we need to think strategically around it as well. Number of line reports, I probably should ask my operational colleagues for a bit of a fit. It'll vary massively.
I think it varies. Sorry, Becky Sutton, Exec Director of Community Health Services. I think it's an interesting point, Fiona, and I have picked it up with some of our teams, that I think it varies. So I think it would waver anything between 1 or 2. I have heard numbers of sort of 30, which absolutely will impact and challenge that conversation around, you can't be line managing that many people and doing all those appraisals. I think some of it's about the hierarchy, and my personal view would be it doesn't always have to be that you can delegate that responsibility. So it doesn't always have to be the overall manager that does everybody's appraisals, and actually it's good development for other people. I think, as Jen said, there's something about the value of the conversation, the time, And certainly one of the things we're looking at is, and I've done it in a previous organisation, like this idea of an appraisal season. So actually you have three months that are really focused within, and we're trialling it in a couple of areas to say you book them all in proactively, but actually it's more about the conversation as well. So I think it does play a part in it, but I think there's other things as well in terms of the value of it and then the actual conversation itself. So I think it's multifaceted would be my view.
Great, thanks for that. Karen, did you want to come in on the back of that one before I move us on?
It's the turnover one, if I.
Let me take Sue first then. Sue.
No, I think we're all after the same information. Sorry, Sue Nixon, non-exec director. Jen, you've answered a couple of points from Fiona, so I think that's really helpful, and you've given us the timescale for the project with IT as a year. Clearly, we're all pushing, I think, to see if something can be done more quickly. My question now also relates to how do we benchmark alongside other colleagues, perhaps not just in this region, but wider afield, and any learning from those people that are more successful in having a lower turnover rate? That's one question. Can I also compliment you on the work that's being done in terms of the people plan, because I think there's a lot of strategic pieces that will interlace and help reduce this in time. But my other point was around the bullying and harassment and respect at work. We've seen a reduction in those numbers. Is that because of less reporting, or are there some genuine benefits that are now seeing fruition in terms of some of that work? I'll leave it there for the moment. I have a lot of others, but I'll leave those as two.
Okay, so just to clarify on the exit interviews, and the point I was trying to make was, even if we implemented a new online system tomorrow for exit interviews, the richness of data to see where the areas of concern and what the trends are, realistically, you're talking 9-12 months, because people do decline to have an exit interview as well, don't they? So that's not around a delay in IT, just to be clear. Secondly, comparator. I'm keen to improve our people performance report at people committee, and we've had many iterations. One of that pieces is around, I'd like to be able to see comparators. Comparing people data in the NHS does rely on having mutual relationships with other trusts, because a lot of the data that comes as a data set is too late really by the time. So to be able to present sort of June data with other trusts would be fantastic, but we need to get those relationships set up for mutual benefit, and that's not necessarily for us an ICS or provide a collaborative piece of work, because our comparators would be other mental health trusts in the East Midlands. So I think that's something we need to look at in the people committee, in terms of that report being not just about us, but about comparators. And I've forgotten your third question.
It was about learning. It was one element was about learning from other people that seemed to be
so
better.
I think
and the other question was about the harassment.
So I don't get a feel that a reduction in cases is because people are not speaking up, because I think Simbi's doing an amazing job in terms of being very available, open, but equally she now has a deputy who adds a different personality, a second person to go to, and might sort of attract a different type of person to bring their concerns. So I don't think that, I suspect, and it's before my time, we've had an increase related to the improvements that were made in freedom to speak up, which actually isn't my portfolio, but it's clear that improvements have been made in the last sort of 3 years, and perhaps we've hit that plateau. That would just be a guess.
Okay, thanks, Jen. And Trevor, just before I bring you in, I just want to go back to Fiona just to respond to a couple of pieces that she said. Fiona.
Yes, thank you. So just very quickly, thank you, Sophie and Daniel, non-executive director. So just to go back on a couple of points, which were just around the survey. And again, it's just more recommendation than comment. So just listen to what was being said, and mindful of the fact that people who are leaving the organisation who may have had challenges or issues with their managers aren't going to do an exit interview with the manager if that's the reason why they are leaving. So again, I think there is an opportunity here to really really review the systems and processes that we have in place, bearing in mind the project that you've already talked about, which I'm really pleased to hear about. But that currently, as it stands, that may also be a challenge, like I said before. And then on average, and for any big organisation, a direct report is normally 1 to 8, not 1 to 30. So again, I think there's an opportunity here to and not just only be thinking about to Becky's really good point about delegating that. It's also about people taking responsibility as leaders and managers for the people that they are leading, because sometimes if it's somebody else, they're not going to really see that person in action. We've really got to think about this much more holistically and broadly. So I just wanted to come back on a couple of points before we close that off and moved on.
That's great. Thanks, Fiona, and some good triangulation there as well. I can see colleagues nodding at your comments there and making notes as well. So I'm sure that's part of what Jen would want to pick up and bring back through the committee. I'm going to take 3 more comments if I can. I'm going to go Trevor, Carolyn, and then Nigel.
Trevor, non-executive. Yeah. I also pick up points about applauding the amount of effort that's gone into the people plan, because I actually think it's really one of the areas that I think might be helpful for us to have a level of visibility is succession planning on critical roles. Because whilst we've got a national issue, we've got to make sure, and I'm sure every role is deemed critical to a level, so I would take that as, but there are certain ones that we've got to make sure that we have backup, and I think some level of visibility may help.
So there is an action sitting with the remuneration committee to bring a executive level succession plan back, and obviously there's so much changed in the last couple of months. It's not a big job and it'll get done sort of in the next probably by next REMCOM. That is not all the critical jobs, however. So then there's a next piece of work to do around identifying. They may be operational jobs within Brampton, for example, where we only have one person that does it, exactly what the plan is. But first step is REMCOM will get an exec succession plan document.
Good. I think that would really help. Thank you.
Thanks, Trevor. Carolyn, then Nigel, and then I propose we wrap this part of the item up. Carolyn.
Carolyn White, non-exec director. Jen, I'm sorry to keep on bashing on the turnover bit, but I just wonder if there is more we could do more quickly, because we're talking about over 1,000 staff a month, I think, aren't we, in terms of that turnover number? And no, I got my sums wrong. No, that one.
I think that's annualised.
That's annualised. Okay, all right. So I've got that right. Nevertheless, I just it's still very high, and understanding within those numbers. So if it's 15% or 70%, there will be areas of the trust where it's even higher than that. And trying to do some focus work on those areas, maybe some pilot projects, something where we can change the system. Because when I've been out talking to staff, managers say we never get any feedback from exit interviews anyway. So there's a kind of disconnect between the process we've got in and the information that's being shared. And
so what I tried to say around the exit interviews is what we've got now is not of any use. So there is if we gave the managers feedback from the exit interview process, it would be of no use. There is a project within Brampton, I believe, around there's a company that's been helping, which we can pick up. So that but then that goes back to, I agree, we need to be doing something right now, which is what I started with, is that we use the data, because obviously we know what the turnover is by team, by ward area. We use that to focus our OD efforts and get into those teams and find out what's happening essentially. And some of that will be about the environment that staff are working in, won't it, and patient pressures. Some of that may well be about poor leadership, and so some of that we can fix. So that is going on as we speak, and those areas of turnover that are higher are not a surprise when you look, because they're flagging red for other metrics.
So do you just want to mention, give us a couple of sentences on this example?
So Forensic has been using an external company for some time. I'm given to understand, I can't tell you the years, and it is across all. It's available to all of the forensic staff if they wish to have an independent exit interview, and actually we're in a better place than the other divisions at the moment in terms of being able to look at our data and being able to say why people are leaving, if it's promotion or other issues in general. So we've got that information and are looking at that, and actually the feedback when people choose to use the independent, it generally does tend to be because they've had a difficult experience. And we've also started to do some work about how we do engage. So even if it's, you know, we can't go through a grievance process or a HR process, for example, how is it we engage with that person afterwards to make sure that although they've had this difficult experience, we can at least repair and have a healthy post experience without sounding too, you know, touchy-feely in that sense. But also, how do we respond to anonymous concerns when people leave? So historically, I would be of the view in this trust that anonymous concerns, we have a bit of a historical stance. We can't do anything. It's anonymous across the division. I think we're sharing it, you know, part of today's papers about sharing that learning. So we're addressing anonymous concerns and identifying ways to flow that through the whole division. So it doesn't matter. It will still be a message out there to say, this is what you said. Don't care who said it. It's important. There's what we're doing, or there's the answer.
Great, thanks, Sue. That's really helpful. So let me go.
I'll just come back. So and the discussion with the senior leadership team was we could have gone with the forensic. We could have expanded the forensics offer, but the feeling was that we could do something bespoke and it would benefit the whole trust. But we obviously can use the learning from Sue, Adele, and the management team there in terms of our own offer.
Carol, did you want to come back to that?
Just one, sorry,
one more
I
bite.
need to, is Sue, with that sounds like a really positive thing that we're doing. Or do we take the opportunity to say to staff, understand that you're not happy here, we will try and resolve that. Would you like a job here, somewhere else?
Yeah, I mean, sorry, I keep forgetting to say who I am, still a forensic director, medical director. We obviously do all of that as a standard, you know, discussion with whoever individually it is, yeah.
And so understanding that in terms of metrics about how successful that is would be really helpful, I guess.
I think at the moment we're not in a position, because it is on an individual case by case, we wouldn't be able to pull that sort of data at all. I think we need to start with the basics, which is, I think, what Jen is sort of politely saying.
Yeah.
I think these are a number of flags that obviously then play into the work that will be picked up through the people committee. And Fiona, I know you'd also reflected that there may be learning from the patient story example that we had this morning, and it may be worth just checking with John Eastwood Hospice. They may have some good practice there. Sure. Nigel, I'll give you the last go on this, and then I am going to pause us. So Nigel.
Three quick points, Paul. Thank you. Firstly, on the wastage, the thing that we haven't mentioned is the large number of retirements. Part of the time story, and I hope that John's going to have an exit interview, of course, before he leaves. Secondly, what I'm getting, Jen, from the way you've answered those questions so skillfully, really, is that I'm getting a lot of confidence that you're on top of these very big issues, and they're not going to be solved overnight, but we're on the right track. So thanks for that. It was some difficult questions. I think you answered them really well. So it gives me a lot of confidence just observing that. Thirdly, hopefully an easy question for you. One of the things that we don't mention or haven't mentioned in my time here is this number of employment relations cases that has been edging upwards. And I have to admit, I don't know what we mean by employment relation cases. Could you just comment on that, please?
Yes, so that is an interesting one. So we have, since time began, I believe, reported our employment relation cases, including long-term sickness cases. Other trusts don't do that. So that figure, if you took, so obviously an organisation of 9,000 staff, I think it's about, from memory, about actually 20 disciplinaries, grievances, capability cases, which is what most trusts would deem an employee relations case. Laura Saxton is doing some work around the performance metrics and the IPR, which I think is coming in September. But and one of the, we've all been, as execs, we've all been asked to look at our metrics to see whether they're still current, if there's anything on the horizon we should be mapping from NHS England. And one of the things I've requested is to split that out, because I think you need to see how many disciplinaries and grievances there are, not how many employee relations cases, because that tells a different story. back to your previous point around some of those long-term sickness cases are people approaching retirement, making decisions around, unfortunately, have come ill at the end of their employment. So they're not always bad news. Obviously, it's awful that people are ill, but they're often managed in mutually with people who are not very well.
So it's a much smaller number than
Yeah.
the causes of concern.
And the people
Okay.
committee see it. I just haven't got that report
All right.
open.
Thank
Yeah,
you.
it's about 20.
Thanks very much. And that's I know we've spent a lot of time on the people piece. It's something that I think 4 or 5 months back, we had a very challenging conversation around some of the concerns. It does feel, as Nigel, you said there, that actually the delivery plan on resolving some of these long-standing issues is moving now. Which is really good to hear, Jen. Thank you. So I suggest let's take a break. I'm going to suggest 15 minutes, just because there's a lot of us in one space. So if colleagues are on screen, we can restart at 20 past, please, and then we'll continue with the integrated performance report. Perhaps not quite as thoroughly, but we'll see how we go. Thanks very much. Yes.
It's still being recorded, or is it?
Let's just we just turn the microphone off on the Restart.
To Becky.
Okay, can I pull us back to order, please? Just before we restart, just to say, colleagues, that we will break at 12:30 for some lunch. So just to note that as we continue now with the integrated performance report. Alison, steer us on, please.
Thank you. Alison Wild, Exec Director of Finance and Estates. We're now moving on to the performance for our operational divisions as at month 3. So I'll hand you over to my colleague for Mental Health Services, Chris.
Thank you, Alison. Good morning, everyone. Chris Ashwell, Deputy Director of Mental Health Services. Just like to highlight a few areas of mental health performance. So firstly, for 72-hour follow-up for people discharged from an acute inpatient stay, I'm pleased to say that that's back on track now. After a couple of months where we fell below the target, we are meeting that quite consistently now. And that is really important. It's such an important safety target, so that's good to see. For out of area ward placements, we have a 0 target for that, and unfortunately we didn't meet that in June. We were some way off the mark really, with out of area patients from Nottingham and Nottinghamshire and Bassetlaw having occupied bed days. So that's a combination of reasons really, but primarily around COVID and cohorting of patients and reduced beds in our own estate. The good news is, the good news is that preliminary figures for July, which are not signed off yet, but shouldn't be far off, we hopefully will be down to about 84 occupied bed days, it's looking like at the moment. So that's in part because of the good work we've been doing to improve flow and reduce out of area, but also we have continuity of care principles signed off with a hospital called Mill Lodge, which we subcontract beds with. That's just on the borders of Nottinghamshire. So that's good news should that figure be signed off, and I don't think it'll be far off, but still some work to do to get it to 0, obviously. For children and young people, for eating disorders, we have two targets there for routine and urgent referrals seen within either a week or 4 weeks. So we are slightly off trajectory on the routine, but met trajectory for the urgent. That's a 12-month rolling target, so you know, we are subject to what's happened previously on that really. But the good news is, if you look at the performance dashboard, you can see that we only had 1 breach for last month for routine referrals, and that was through patient choice, someone who chose not to be seen in that 4-week period. And for the urgent referrals, in fact, we had no breaches and haven't had any breaches for a few months for that one. So that's really good, and I think we should be hopefully on track in Q2 to be meeting that target. In terms of assessment for treatment, assessment, weights for assessment and weights for treatment across mental health services, you'll see from the charts that we do have some outliers. On the whole, we're not too bad at 96.4 for assessment and 93.7 for treatment. But as I said, there are some outliers, services like memory assessment services that we're working on, have recovery action plans for that. What I wanted to point out was step 4 city psychology, actually, where the weights reduced in a year from having 144 people waiting to only 59 people waiting, still too many, but good progress. And the average weight going from 57 weeks to 18 weeks. Now, what happened there is we invested in additional staffing, managed to get the staffing up to near full complement. And I think what that demonstrates, and we see it in our other services, is when we can get our staffing up to or near full complement, then it does have a, you know, quite a significant impact on weights and number of people waiting. Thanks. I'll take any questions from there.
That's great. Thanks very much, Chris. And a couple of good news stories in there, or at least good direction of travel stories in there, which were really important to draw attention to. Sue S, please.
Thanks, Chris. That was really helpful. The question I had was around the IAPT, and it's a comment that's under the 90-day treatment where it talks about workforce capacity may be affected due to the changes in the contractual arrangements. And my question is, have we got a plan in place to manage the transition re this contract so that we minimise any impact on patients?
Yeah, I mean, at the moment, strictly speaking, we don't have a plan. What we have is a working group with the ICB now weekly to form the exit strategy for that. So we've committed as an organisation not to just stop taking referrals because of the impact that would have on IAPT as a whole. As you know, we only provide a proportion of IAPT services across the county, and that's only in the city and the south. But we're working on that. But what we are trying to seek from ICB, our commissioning colleagues, is assurance that they are working on the plan with the other providers to enable us to stop taking referrals. And we think that should be any time now, really, to stop there being a huge backlog of patients at the end of it who will be sat with Notts Healthcare, who will no longer be providing, of course, that service. So that's what we're working on with commissioners, and I think over the next couple of weeks we should have that exit strategy signed off.
Great, thanks, Chris. Nigel.
Thank you, Paul. Hello, Chris. I'm interested as usual in the out of area placements, but the more I've looked into these figures, the more I think I'm looking at the wrong things. There's this thing called total non-NHT placements, which I think, and it's the question, just if you could clarify for me, these are the placements that we subcontract to private providers because of a shortfall in our bed capacity. Is that right?
Well, it would be that. It's a combination of that and the spot purchase beds, either in area or out of area. So it's a combination of all of those. And that target really is impacted by our own ability. So you saw where it's gone up. It is primarily the issues we've had around bed flow. So if I give you an example, the 2 dormitory wards that we have in adult mental health, 19 and 20 beds, they only have a couple of single bedrooms on each of those wards. So the one in Mansfield has a capacity of 20 beds. When we've had COVID outbreaks, we've only been able to use 12 of those beds. So that's 8 beds that we've lost from our own capacity. And you can see that obviously leads to, you know, having to find that provision elsewhere. And that's the reason for that figure.
Nigel?
That figure seems to have been, it's not entirely consistent on trend, but it has been edging upwards. We heard from Hazy yesterday about some work that she's doing to try and bring this down. Is the reason for the increase related to the pandemic outbreaks then?
Yeah. I think it is primarily around COVID. There are other factors. You know, sometimes we might have issues with our own subcontracts in terms of why they've reduced their bed numbers, that, you know, we try and work closely with them. But, you know, sometimes there is a reduction in that and we have to seek beds elsewhere. But it is primarily around COVID related stuff. But as you said, there's some stuff in the paper. We're doing some really good work around flow and around discharge. So we use some of our discharge monies that we've got nationally to purchase extra provision to move people on. We're doing improvement work around length of stay and try and reduce that, targeting certain areas. And of course, we have a quite significant number of patients who are medically fit for discharge and have been for some time, that, you know, generally speaking, local authorities can't find placements for because it's a specialist placement. So it is a combination of factors, really.
Okay, thank you, Chris.
Thanks. Okay, let's Move us on if we can, Alison. Thanks, Chris.
Thanks. We'll continue with our operational divisions and move on to community health services performances at month 3.
Thanks, Alison. So Becky Sutton, Executive Director of Community Health Services. There was just a couple of points to take the report as read that I was going to pull out. Not going to repeat the earlier conversation around the urgent community response indicators, as we mentioned those. What I did mention though is there's an impact on us moving resources in some of our planned care waits. And if the board recalls, a few months ago I brought a deep dive paper around the waiting times in community that aren't routinely have ever been measured before. And what the report this month shows is some long waits in some of our nursing pathways, particularly around continence. And again, this is a new report that we've never actually measured before. So I think whilst the figures look quite large on the report, so a fair number of patients, we've got quite a big piece of work to do to understand what those waits are for, and actually whether they are waits for treatment or actually people are waiting because they've trialled one treatment plan and actually are waiting for another part. So at this point in time, although I am concerned and I'm highlighting it to board, I will bring back another report in terms of what we're doing about it. What it does show though is every time we move our resource around community, it's waits like these that get impacted on. So, you know, things like you know, we may say, you know, continence is a lower level intervention. However, it soon starts to add up. So we will be doing quite a lot of work around what we can do about that and what we class as a wait, because I think you can't always use the same definition on pathways. So we are doing some work on that. The only other bit really to highlight from the report is what you will see is the other area I report on quite a lot is podiatric surgery. We are starting to see that wait time recover, and again that was as a direct result of different waves of COVID, so that is starting to come back to pre-pandemic levels. Again, just a word of warning for this month that isn't in this report, we have been escalated through that unit of management that they are seeing referral rates going up. So again, I think we have to just watch and wait, because I think there's a number of patients that have decided not to come forward for different treatments and services during the pandemic, and I think we will not only see a recovery backlog, but we will see an increase in referrals for things like podiatric surgery, which people have waited for. So I think it's just all of that, how we recover and how we manage new waves of COVID as they go forward, but we're doing everything we can. The other bit just to assure is we do look at those patients by clinical urgency rather than the amount of time they've waited. So they're triaged quite regularly to understand the impact on individual patients, and we will see them in the order of clinical urgency rather than how long they've waited. That's probably all, Chair, but happy to take any questions.
Thanks. So you've given us a flag there that you'll bring stuff back in detail. Nigel?
Thank you, Paul. Becky, I'm on page 26 on the wait times, psychological therapies. I did a visit with one of the governors last week to the psychological therapist team, Byron House. Obviously, a question came up about waiting times, and they said very clearly to us that the average waiting time for their service was 9 to 12 months. Appreciate that might be part of trust and rather than all of it, but that isn't tying up with the graph. Is there noise in the figures, or am I misinterpreting what they told me?
I think that's a different service line, and that one sits at mental health, and it's the confusion around community teams.
Okay,
And I'm
I'll
looking.
take that with you offline.
Yes, no, we'll take it offline. I think it's adult mental health.
Okay, thank
Nigel.
you. There are some nods around the table at that bit, so perhaps there's a sideways conversation. Nigel, thanks. Alison, steer us on, please.
Thank you. Just our final operational division, over to Sue Elcott for Forensic Services Division.
Oh yeah, Sue Elcott, Forensic Director and Medical Director. I've not gotten a lot to say. It's very similar to the last sort of 3 months board IPR for forensic in terms of the focus on occupancy. I think the other issue that's already been covered in detail is obviously our staffing, because that is covered under quality metrics. But you'll see that particularly Brampton, again, the staffing availability, which we've discussed in the past, covers a whole range of things, is really dropping, and the work that's being done. I'm just flagging, without giving any detail, that there are discussions under the National High Secure Collaborative and Clinical Secure Practice Forum about the situation across the 3 high secure hospitals who have a similar slightly variable position, but that's the main risk for all 3 at the moment. So just to flag to board that that's being discussed sort of vertically as well as horizontally, so to speak. So I'll stop at that point.
Great, thanks, Sue. Paddy.
So could I just pursue that point a little bit? It's across the piece. What are the reasons for it? Does anybody know?
Some of it's about numbers. So if you look at the size of the services, and actually of the 3 high secures, we're not the highest vacancy factor. So I won't obviously just, go into that. But from our point of view, some of it is our geography as well, because, Brampton sits in the midst of a very rural area. It has quite a confined geographical location that people could commute into, etc. So there isn't clarity at the moment as to why that, other than the sheer demand. There is also work that we're looking at in terms of the use of some of the clinical practices, in terms of the use of observations, zonal observations, the amount of restrictive practice, and the staffing that's then associated with the sorts of numbers that we're looking at there, because compared to any other unit, it's immense. That's probably not the right word to describe it. I'm trying to think of something better. But so I suppose what I would say, and we've talked about this before, is that all the mitigations are in place. We are monitoring what we're having to do. So, for example, if we have to do any early night confinements, we're monitoring that and bringing that through. We're managing our patient activity. That hasn't dropped if you look in terms of the performance on that. We are at a point which I don't want to bring yet to board, but again, we are looking at all of the options that perhaps we haven't yet fully established, because they might not be preferable, but also how do we engage, and we talked about this at Brampton Improvement Board, how do we engage with patients on what is actually preferable, because when we did some of the restrictive practice work and when we did some of the work bringing in night confinement, patients' views are actually quite different to what the staff at the time, colleagues, were thinking. So we're just working through that piece at the moment. So there's not a simple answer. There's also a sort of lack of professional identity and respect, I think, for inpatient nursing as a profession, and they've talked about that nationally. Needing to do a piece of work of that, because we do across the patch bleed out from, and Chris will be in the same position in mental health in particular, nursing staff coming into inpatient areas, shift work, I'm not dismissing any other work, but it's a very hard place to stay in longer term, and people now can very quickly move up the grades out into quite interesting, all these fancy posts, so to speak, and we're not valuing the core posts.
So I guess where I'm getting to is, if there's under-occupancy across the 3 secure hospitals, the danger is that there'll be some decommissioning.
Well, that's referenced in the narrative, that there is the potential. It hasn't been raised. So we've had the high secure capacity and demand. It's the right way around. High secure demand and capacity programme is ongoing at the moment, which they have to do. And part of that is to do the National Service Review every 5 years, which has been completed and has said no changes for the next 2 years, which is in the report, but it's always a potential.
Right, okay.
Jen, did you just want to come in on the back of that?
Just to follow up on why we're not attracting, but obviously COVID has reduced the opportunity for people to go and see places that they don't really know what goes on behind the closed doors. And I know Anna's moving on, but one of the things that Anna asked me when I went on a visit to Brampton was about doing some more communication around what it's like to work. So we were looking at, we've started pushing out with the comms team, thank you, some videos around what it's like to be an adult inpatient staff nurse, but we're keen to do some of that at Brampton, of what it looks like inside, and because obviously everyone can't go on a visit, but that hasn't really been possible the last couple of years. But I think that's an important piece of work as well, around education and attracting people who might already belong to not healthcare but may well move.
Great, Thanks, Sue. Alison, on to the final part.
Thank you. Alison Wild, Exec Director of Finance and Estates, here to just highlight the financial performance of the Trust as at month 3. So as at the end of the June, we had a surplus of 78,000 against a revised plan, which was break even. We are still forecasting a break even position at year end. However, within that position, we've talked about the challenges in terms of workforce. So pay is currently 2.7 million under plan, with expenditure of 1.6 million on agency, reflecting the conversations we've had earlier. In terms of non-pay budgets, we're over plan by almost £1 million, and that's to do with the out of area beds that we've talked about in the mental health section. So in terms of agency and national guidelines, I think I refer to page 69 on the agency forecast versus our indicative cap. We have, since the writing of this report, been given our cap, and that's likely to be about 12.6 million, so better than we were anticipating at 10 million. But there is still work to do in terms of about 1.5 million reduction in agency that we need to address, and also that's got an impact on in terms of quality of care for patients that we need to think about, and how we've got some projects going that will reduce agency overall. The other thing to highlight is that on page 70 is the FIP and where we are on that. We're currently reporting to board at £8.6 million gap. However, there's considerable work that's ongoing, and we had Finance and Planning Committee yesterday where we are moving forward on closing that gap. What we aren't able to do is to report that to board as yet, because we've still got to go through the risk assessments and quality impact assessments and draw those schemes up to be more defined. So there is considerable progress, but at this point we've got a gap of 8.6 million. Capital, we are currently reporting a position of break even. However, there are significant challenges on our capital programme, particularly on mental health dorms and general inflationary pressures due to the national and international, if you like, pressures in generally. So we are managing those within the capital programme through the Finance and Planning Committee, and we will be continuing to closely manage that, but there are risks in that position of a break even. I'll pause there.
Great, thank you. Any comments or questions on this piece? I think given that there was a meeting of the Finance Committee yesterday, there's probably been quite a lot picked up there, Alison. Okay, we're asked to note that report and all the escalations, and indeed I think there's been a lot of challenge and discussion there for us, so thank you for that. Let's move on to item 12, the Forensic Division Improvement and Learning Report. Sue.
Thanks, Sue Alcott, Forensic Director, Medical Director. So I'm going to preface this with, there's an awful lot of information in here, and I'm aware that it's public board, and so the offer is if anybody wants to have, you know, more individual discussion on some of the elements, given that some of you will have more or less understanding of the services, etc., then I'm perfectly happy, you know, would actually be pleased to do that. So the purpose of the report really, I think, is twofold. One was, in previous CQC inspection, one of the issues was identified is that we're not great at being a learning organisation, and actually what we wanted to do was to show where we have done learning and show to the board the learning in the division, the learning across the divisions, the learning across the trust in that sense. So that's an important part. It's not just about the forensic division. Secondly, it is about the forensic division, as you'd sort of expect me to do as well. The first part of it describes our services, and I think it's quite difficult to give you an identity of what the forensic division is, and writing this brought up what is our identity. So we've agreed we'll do a piece of work around that, because we are diverse. You know, people talk about Brampton, and often historically there's a view that the rest of the division is ignored, or it feels not as attended to or not as important, etc. So that's why I've been really clear about the range of services, because we provide, in terms of forensic services, across all levels of security, we provide pretty much most sort of standard elements in terms of specialties. Then we have offender health Offender Health has always had a view that it should be its own division. Just tell you that for history, and it is huge. You know, it doesn't. It provides 3 types of services. It provides physical health, provides mental health, and substance misuse. Proportionately, probably the highest amount of that work is physical health in terms of the strands across 8 prisons. You know, so it gets slightly. So we're doing a piece of work that Yolanda's talked about in the past about branding for Offender Health in its own right, because when it's trying to recruit, it has. You know, it has diverse geography right out to the East Coast, right the way down. We're just recruiting into the new prison that we've got the contract for, HMP Fossway down at Northampton. So I wanted to give you a sense of what it is, because it's not easy sometimes to feel. And then you heard last board about the Veterans Service as well, which again is a bit left out and lost in our division. So that's that in terms of services. So I'm a forensic psychiatrist by background, and I came back into the trust. So I was a baby doctor here. I always use that phrase. I trained here. I'm passionate about our forensic services because I learned here. So I just give you that. So if I sound slightly passionate, that's because you know, I view these as part of my development, etc. So coming back was really important. And the first thing that we said was, this isn't about doing anything for the CQC. The goal wasn't about, you know, improving our rating, because it is what it is, no disrespect. Actually, what I want really clear is for our services to be proud of what they provide, because they used to be, and that you could feel that had been lost, as happens in all, you know, services go up and down, they all fluctuate. It's just the time you come in, just to put that out there. I think we were quite shocked by what happened when the CQC did their unannounced inspection into Seacole, the female ward at Welsh Road, and I think that was, in essence, the sort of, I can't remember if it's you, Anne-Maria, somebody uses the term burning platform, and it wasn't the burning platform, but it was a precipice of, actually, come on, this isn't good enough. You look at those examples of what are being found, why didn't we know about them? And I remember some challenging board conversations early on about that. People that know me know that I want to sort my own house out. I don't want anybody else to come in and do that. I think it's important, if you own it, it's, you know, you want it to be as good as it can be, which was what the aim, I suppose, was within the division, to give that sense of responsibility and autonomy and authority back to all of the management teams. So I'll take it as read, and it is very complicated. Some of it would be easy as a picture, but I'm not a picture getting it into this format person. So the first thing as a theme was, where are our management teams? Can you imagine? I spent the first 3 months asking people at Brampton, who is in charge? Where are decisions made? You know, and that's not a disrespect to any of my previous, you know, people that have held this post or other posts. They've done a number of management changes over the decades. And I'll say that because I was there in 2005, I started. And the structure had been changed as people retired, etc. All sorts of, then there've been conscious decisions made across the division, but we'd ended up in a bit of a sort of lack of clarity of, where are the management teams? What are the management teams made of? So in other areas of the trust, there'd been a decision to go for triumvirate approaches, so that you would have a general manager, and I use the terms generally because people have different titles, but you'll have an operational lead, roles responsibility is really clear. You'll have a clinical leadership, stroke clinical director, whatever, again with clinical leadership, and you will have a head of nursing, stroke AHP, stroke quality, depending what your structure is like, that looks very much at the thread of quality. We didn't have that in place, so we agreed that that was what we would look at. We wanted to mirror the executive team in terms of roles and responsibilities and portfolios at a divisional level. The other thing that we looked at was the governance, and again we wanted to mirror the way that the governance was set up from a board and sub-board. And I think in the paper I've talked about Adele, who's my deputy forensic director. Adele and I spent over 3 hours with stick hits trying to actually find out all the meetings that all of the divisional colleagues went to on a board, and to find out where they reported to. I didn't put the picture in because it wasn't very clear, but it was an absolute mess. So our governance wasn't right either. So we said, we've got to get our foundations right. It's taken longer than I anticipated, and each of the general managers that's come in has had a similar experience, which we've talked openly with each other about, that it's not failure, but it's taken us longer than the first 6 months that we thought. So we've got clearly identified management teams now. there wasn't a general manager. So the biggest changes in effect were at Brampton, and we went through an organisational change process that people will be aware of. If I tell you that I managed half of, or my post managed half of the division, and then the deputy managed half of the other division, we've completely restructured that so that it's very clear I'm the director, the deputy director manages, and then we've got directorate management teams for each. We're just working through the appointments that involves. There's been an awful lot of retirements, people moving on, and that's enabled us actually to do some of this without too much, I don't mean this in a rude way, Jen, but HR process, because it's just been naturally evolving. So we've now got really clear teams. We've got really clear roles, responsibilities, accountabilities, so we can see the flow. So we've got the foundation. So this isn't perfect, and we're continuing to learn, but at least we know, who's doing what, etc. The governance is the same. So we had some support in terms of somebody coming in to help us with that. The management teams took to this like I thought I'd meet resistance. They absolutely welcomed the work on governance, because they also started to question, well, how do we know about this, and how do we take responsibility for our own services if we don't have this coming through? So I know people sort of say about the flow board to board, but that's the process they've been going through. We did it slightly the other way around. We used the terms of reference for, sort of the DMT mirrors, the exec team, and we've now got structures for quality, finance and performance, security. Health and safety was lost in the division, so that's now got a clear thread and roles and responsibilities of that. So as a theme, the governance wasn't right, so we couldn't see one picture. The other thing that had happened was, and this is trust-wide implications, was there's been a lot of work. I think John early on sort of said with previous CQC inspections, governance was picked up as a problem. So there'd been a lot of trust-wide governance work, but what hadn't been translated in our division was, okay, if you're having trust-wide accountability, which is absolutely right, and assurance and principle setting, so as the different divisions don't go off and do exactly what they want, which I absolutely support, we'd taken out some of our doing. And so a couple of examples of that, which come in my medical director as well, so it was quite good being able to talk to myself about it, was medicines management. So we've got a central trust medicines optimisation group by way of example, but we had nowhere for that to fit into. So there was a central meeting and nowhere for that then to flow into the divisions, and where was the divisional accountability at each of these service levels. So we've now got across the divisions, and I would say, thanks to Becky and to Julie and essentially your associate medical directors, Anna Hiley and Hazel Johnson, who's since retired, but I mentioned my own as well, Mark Taylor, who took on that mantle of sorting out the governance for those and for mental health and mental capacity legislation, which was nowhere in the divisions. So so that's why I'm trying to emphasise it's not just forensic, it's divisional wide learning. So I'll move on in terms of that. The other thing that we've done a lot of work on, I mean, I could talk for hours, which I won't. I tried to limit it to the work on culture, because we know that one of the biggest things, the forensic division does definitely have a certain flavour to it, having been part of it, having been brought up in it. Only stepping out of it did it make me reflect on going back, and it felt very different to when I went to work, say, in Lincolnshire or Leicestershire, where there's much smaller forensic services, etc. You're not part of a great big forensic division. We've done a lot of work on just and restorative principles, but we've also done a lot of work, and I think it's important that you're aware, on where behaviours have been unacceptable, have perhaps been unacceptable for years, but tolerated and seen perhaps as banter in some cases, which I'm aware of, to deal with those and to say it is no longer acceptable. We do take an educational stance on it, taking into account people's cultures, backgrounds, where they've been brought up, their family experiences, etc. But ultimately, we're talking at the moment about how to use some of those examples so as people can hear some of the experiences of some of our staff, which when you hear it directly, at times has been very upsetting for some of my manager colleagues, and then you hear it. So we're doing the whole gamut in terms of culture. And then I didn't want to finish without sort of saying, because it wasn't about the CQC, but she says, the management teams and the staff have been so proud, because the way that they've done it is we showed off how much we'd improved, and that we'd listened, and this is the feedback. Now I've put it into the reading room because obviously some colleagues are new, they won't have seen it, but the CQC report on the low secure and medium secure units, bear in mind this isn't Brampton, so please remember that's a separate report, you know. So we went, you know, originally in terms of well-led overall, we were requires improvements. Then we went down to inadequate when CCOL was re-inspected, and then we've gone up to good now. So the teams feel like this is validation, and feel proud. But I couldn't also end without saying a little bit about staffing, because it is the biggest thing. We had, for example, Brampton Improvement Board the other week, and it is the biggest thing, and everybody's really anxious. So it felt wrong to do a paper that just didn't just balance it at the end with that bit of, we're not, you know, we're not, I will never use the word complacent because I don't like the word. We're not stupid, we get it. It's not all perfect, we're absolutely not saying that, but we are proud of what we've achieved over the last couple of years. And I think that's the point, you know, other divisions, we're all working together much more closely now. So I'll take any questions.
Great, thanks, Sue. And just before we go open it up, just a reminder of your opening statement there, Sue, about saying that, you know, you know there's a lot of detail in this, and you're very happy to have one-to-one conversations. So I think it's really important we just keep it at the board level. Anne-Maria, do you want to start us off?
Yeah, I just want a couple of comments really. I just wanted to say that I think that I've been really kind of like impressed with what Sue did when she came in. She kind of like almost did a bit of a diagnostic, but I think it's a really good case study. It's a really good story. I think a lot of people can take it. One of the things I think she hasn't highlighted that she did do very, very, very well, she took the CQC improvement plan that people had just sat on and hadn't really engaged with it, hadn't realised the importance of it. And what she did is she really showed the importance of that as an improvement plan, but also the ownership of it, giving responsibility for the work that needs to be done and the sustainable change that needed to be done, and the evidence. So she never let go. She kept saying, you know, where's the evidence for this? Where's the evidence for this? Where's the evidence for this? But she also ensured that when we did do the CQC briefings, when we did do the CQC kind of like workshops, there was always people there and they knew what their role was. They knew why they were there and they knew what they had to take back to do. So it's more comments really just to say that I wanted to reiterate she's done an amazing job.
Great, thanks for that. Carolyn.
I just wanted to say the same really. I think, Sue, your passion does shine through, absolutely it does, and this is a piece of work that I think will just continue to reap benefits. It's probably been long outstanding, I think, but yeah, well done, because it isn't easy to take people with you on this journey always, but it sounds as though you've done an amazing job, so thank you.
I think the team, you know, I know everyone says it, but you couldn't do it without the team, and they've all really got the passion for their areas as well. And for being a division, it's the first time many of them have said, we've got a division, we've got an identity, we've got a home.
Great. So I've got Trevor and then John, and then I'll put a wrap up on it as well. Trevor.
Trevor, all non-exec, and yeah, your passion does come through, which is really encouraging to see, because if you try and do these things, if you're not passionate, it won't happen. So all credit to you for that. You said about your style is not to use visuals, but to use words. But I would encourage you to make sure that you've got a visual way of sharing the journey, because different people pick up different messages. And if you can see the navigation of the journey very simply, then you can get people on board. Because I think critical about this is sharing, and you can do that in 2 minutes. Sometimes you might get 15, sometimes you might get an hour. But I would strongly encourage you to make sure you use different mediums to share your message, and sometimes it's 2 or 3 bullet points so that you walk away that everybody's got that same message of how you approached it, what you did, and what the outcome is, because it's a really powerful story. But it'll be more powerful if it's shared, you know, in a variety of ways.
Thanks, Trevor. John.
Yeah, it's a brilliant, thank you. when the forensic director vacancy became available, I texted Sue because I'd obviously know her, and her instant reply was, "Just exiting Tokyo Harbour on a cruise with my mother. We'll get back to you." I'm pleased that you did get back to us. I won't repeat the other comments. My broader point is evidence, superb work led by Sue and the team, but how relatively easy it is for, whether it's a division or a directorate or wider parts of the trust, to get into a bit of a mess, despite, for example, the board or the executive team thinking things are okay. And it's that sort of almost hidden in plain sight. You have all this infrastructure, you have all the committees, everything's okay, you come to board, you say your piece and it gets signed off. Actually, the forensic division was in dire straits, as were many other parts of the organisation. I think it's a salutary lesson for the board about how relatively easily that can happen.
Yeah, great.
And testament to what can be done about it when you face it head on.
Yeah, absolutely. So Sue, a really important paper for us. I think, as I read it, there was the whole arc of the improvement journey that you described there. But for me, it's stating the obvious, and colleagues have said this in different ways too. It's also the improvement journey that you've led in that. And I totally appreciate your comments there about the team, and also there's your leadership of that team, which has been a really important piece on this. And I'm sure that certainly for non-executive colleagues in particular, will have been a really welcome capture of a great deal. So thanks for that. An important one for us to be putting into the public domain as well. Okay. Let's move on, if we can, then to Alison, an update on the eradication of dormitory accommodation capital schemes, please.
Thank you, Paul. Alison Wild, Exec Director of Finance and Estates. The report's here for information to give you an update on where we are in total on our eradication of dorms for mental health acute beds. We are, in terms of context of this is about where we are in terms of progress against the scheme, rather than, and I'll outline some of the challenges that we've gone through to actually get where we are today. So in terms of this is a national, it's a national scheme. There's a national drive to eradicate all our dorms in 5 years. There is a timeline in terms of our critical path that's attached to this report. Just to really highlight that timeline is initial, and it's moving daily as we're working through the capital programme. And in terms of timelines and Sherwood Oaks, I know some of this is highlighted in the report, but I just wanted to go through a bit of context and background to Sherwood Oaks. So Sherwood Oaks was purchased from St Andrews and was a very similar property. We anticipated that this would be a bit of a redecoration and refurb, and be a smaller scheme up to the value of £5 million. On purchase of that property, and after a lot of due diligence, it was discovered that the building wasn't compliant, particularly in relation to fire safety and fire regulations following Grenfell, and some of those things that couldn't be discovered in the due diligence that we actually did at that point. So in terms of where we are against the scheme, Sherwood Oaks is now, it's had a completion date of the 26th of July. We've not handed over contractually as yet, but we have got staff in there doing the, lost the word, orientation. Thank you, Becky. And then patients expected in there in October. So some minor work still continuing, and that is impacting on our critical path for other or for the rest of the dorms programme. Our next stage in that is our Millbrook, which we are reviewing the outline business case that's already come through, and we are reviewing in terms of the scope of that, given the capital challenges and availability of resources that we've got as a trust, as a system, and nationally in terms of capital resources for dorms. So in terms of going forward, we have got challenges, and the challenges are about timelines. We've spoke earlier about the CQC warning notice about our progress against our dorms, which is why it's important this report comes to board today to give the progress on where we are against this. We have got a critical path in terms of that, and that is slipping at the moment, but we are doing everything we can in terms of moving as quickly as possible on that critical path. But we have got some restrictions in terms of availability of resources, which is a major challenge for us at the moment, and particularly about inflationary pressures on capital schemes, given the national and international and global position. So I don't think we're unique as a trust in terms of those inflationary pressures. We are unique in terms of Sherwood Oaks and the particular challenges of compliance that has delayed our programme. So the report is here for an update and for discussion. Finance and Planning Committee have been through this in quite a lot of detail, and the backing information and the challenges financially and otherwise that we are going through at the moment, not least the financial challenges that are being managed through the capital programme.
Great, thanks Alison. And just before I open this up, just to say both in terms of the public record, but just for colleagues as well, I'm aware that we've got a separate paper on this in our part 2 meeting, which is in part 2 because of elements that are absolutely confidential, things like commercial sensitivities. Just to basically say, just remember which bits of paper you're referring to as we get into this, so that as a reminder, we're in the public domain. Nigel, I just wondered if I could ask you if there's any comment you want to bring in from the committee that got referenced there.
Yes, Paul, thank you. I think if I could reassure the board that the extraordinary Finance and Planning Committee, I think it was the 7th of July, went through the Sherwood Oaks scheme in particular in great detail. And we've been focusing on not just the costs, but the timescales and the slippage involved that Alison referred to. What is clear about the eradication of dormitories programme is, firstly, it's going to cost a lot of money, a lot more money than anybody thought. And we haven't got a lot of money at the moment. That's the first thing. Secondly, it's going to take a lot longer than anybody thought. And I'm conscious of the what CQC have said about it, but there is a bit of a reality check on what we can reasonably do, which we'll no doubt come back to later on. I think if I could just get some clarity for this session, I think the important point is, if we can't deal with this straight away, which we'd very much like to, what is our plan to deal with the eradication of dormitories? And looking at the critical path, I think it's important that we have an understanding of when, on the current set of assumptions, taking account of all the caveats that Alison's mentioned, when we'll be in a position to say we don't have any dormitory accommodation. And I think, and it's a question that I'm gauging from the paper, that might be as late as 2025 or even 2026. Is that where you are, Alison, with that?
Yeah, I can just clarify that. Chris may want to come in on this, but with the Cherry Ward business case that went through a Finance and Planning Committee yesterday, that is just it's not an outline case that we're going to proceed to. I think that takes us at least till 2025, so patients probably 2026, but we are looking at ways that we could try and do that in tandem to others, but it is about having the availability of beds, enough beds to house patients while we're going through that critical path. But I know Chris and his team are looking at any way we could possibly pull that forward, but there is a balance, and let's be reasonable, there is a balance of risk in terms of financial versus the actual timelines for doing this. So it's a difficult situation, but we've got to be realistic in terms of finances and timelines and how we balance that.
Chris, did you want to add anything to that?
Thanks, Paul. Yeah, Chris Ashwell, Deputy Director, Mental Health Services. Just to echo what Alison said, really, if you look currently on the critical pathway, I think it will take us around that time. We did think that there would be a facility to commence Cherry whilst with some overlap with Millbrook on the original plan, because of the facility to decamp patients into Kingsley Ward. That's not now available. What I think we need to look at is the capacity for decant of patients, which could affect pulling this forward. And of course, that potentially almost certainly will have revenue implications. I think if we do that.
Right, thanks. Thanks, Chris. And I think there's a sort of a mix of sense here about Nigel referring to that reality check, but also us being absolutely continuing to be committed to eradicating dormitories, and any along the way. The mitigations, we just need to be as creative as possible around those mitigations and things like decanting, but anything else, I guess I'm saying from a board perspective, please just come up with any ideas, any approaches with an absolute focus on mitigating the ongoing dormitory piece, because it isn't all dependent on us having the build stuff right. It's about what we can do along the way. Anne-Maria.
Yeah, I know that it's been quite financially driven conversation so far. I would just like to leap in with my bit of quality hat, if that's all right. I think that we underestimate the impact of living long term in a dormitory, and I want to just say that the impact for patients and staff as well. And we saw that throughout COVID as well as pre-COVID. There is a very, very good reason why the eradication of dormitories came about 8 to 10 years ago. It was a big thing that we really had to start thinking about for the experience, the patient's experience, the carer's experience. And this comes from both privacy and dignity, sexual safety, and all of those other aspects of incident control. To be in a dormitory with somebody that is very, very unwell, and also the incidents that occur with regards to that. So I wanted to put in there, I know we're talking money here, but this is about the right thing to do for patients. I feel so strongly about that, so strongly.
You underline, there's nods all around the table, Anne-Maria, and you underscore that it's an important piece of the public message for us to put out there. Okay, thanks very much, Alison. And I do take some comfort from the fact that I know that committees are working very closely with you and ensuring that there is some challenge and further scrutiny in these really important but complex pieces of work. We'll move on to item 14. Just to say, we're going to move our lunch break by 15 minutes, so which I'm hoping will give us time to complete part one. It would be sensible if we could. So take that as the flag it is, because there's a couple of bits at the end we need a bit of time for. COVID-19 decisions and derogations. Becky.
Thank you, Paul. So Becky Sutton, Executive Director of Community Health Services, and for this paper, emergency planning comes in my portfolio as well, if you think that's a very strange one for me to front. So this is a paper that's been to board before. It's been coming all of the time through COVID, and since we set up our incident control team, or our ICT meeting. So what the paper is here for assurance, and it demonstrates the governance framework that we have in place around any decisions or derogations as an organisation we've made during that period. This report looks for January to July, where you will see there was 27 decisions and derogations made. Obviously, they're open and closed in a timely manner. So we meet as a incident control team weekly, and new derogations will be opened and closed. So it's never standing still, really. To date, and bearing in mind this was the 20th of July, so I don't think it includes derogations I talked about earlier in terms of some of the community health services. We had a total of 1 active decision and 3 derogations, of which the detail is there for people to see. And again, this is here for assurance. We have a very robust process. We identify a number of decision-making points around any derogations, which for people that don't know are things that we would do differently with, you know, in a normal circumstance. What we have done to that log is back end, probably 6 months ago, we added 2 things to those columns. What might be the potential risk of that derogation, and what could we put in place to mitigate that risk? So it's a very robust process. It's here for assurance, and very happy to take any questions.
Great, thanks. Sue S, please.
Thank you. This is the first time I've seen this report, so I found it really useful. I've got 1 comment and 1 question. The comment was around the column that says when an item's closed or active. Given it covers quite a long period of time, it'd be useful if you could add a date in when it was closed, because it gives a feel for how long it was actually needed. And then my question was just a fairly detailed question, I'm afraid, but on the second one down, it's showing still active, but the approval was only till the end of May. So I just wondered whether that had missed being updated, or just looking at it from assurance purpose, it didn't quite tie up.
Yeah, thank you for that, Sue, and thank you for picking up. In terms of that, yeah, we can add that column on. It is all logged as part of our ICT in terms of when they go. Apologies, the second one, is that on the, are you referring to the spreadsheet with the detail in?
I am, yes.
Okay, so I'm happy to take that outside. I would think it's just a missing date in terms of we haven't updated it, Sue, so I'll take that back through ICT and make sure that's redone, if that's okay.
Thank you. Thank you.
Great, thanks very much. We're asked to note the decisions and take some assurance from that process. And just to clock that this, the ongoing versions and iterations of this are going to be really valuable as and when we, as a trust, are contributing to the national review work around the response to the pandemic. Okay, let's move on if we can, please. Alison, to the mid-year position update, please.
Thank you. Alison Wild, Executive Director of Finance and Estates. And just for the minutes, that those of you who are on the ball today might notice it's not a mid-year position, is it? It's the first quarter, so apologies, there's a title error that we need to update in the minutes. Okay, so in terms of this report is here on charitable funds, and it's for an update, and it's to update you on the 21-22 unaudited accounts and the 3 months and the performance of 3 months up to the 30th of June this year. In 21-22 there was a total gain of 134,000, and in 22-23 for the first 3 months there was a £95,000 loss. That's a symptom of the financial climate that we're working in at the moment. There is a few items of spend that are of significance that have contributed to the patient experience and staff experience this year. And that is the George Cross badges, particularly the Queen's Jubilee celebrations that we're able to allocate out to for bids from teams to help the patients and staff celebrate the Queen's Jubilee, and also the Highbury classroom. Just to note that the income mainly comes in through donations, and the total income for this financial year was 62,000. So the report's here as an update only, and the accounts are still to be audited for the charitable funds. I'll pause there for questions. Thank you.
Great, thanks very much. Nigel?
Thanks, Alison. There's a paragraph on page 88, second paragraph down. It says where the funds are being held, and says that they're considered to be responsible ethical investments. The question is, considered by who? Have we got some independent verification or clarification to say that they are responsible ethical investments, or is that just someone's opinion?
I need to come back on that. I'd have to look at that for you, Nigel. I don't know if that's somebody's opinion or if it is a national position on charitable funds.
Okay, sometimes
the detail.
these funds have an accreditation done. I think it's really important for us to know £1.25 million is being invested ethically, given our values as a trust.
Yeah, absolutely. I'll take that away and take that as an action. Thank you.
Good challenge. Thanks, Nigel. Paddy.
So Alison, the funds are with two different investment managers, BlackRock and CCLA. What's the performance between the two of them?
I don't know the answer to that one. I'll come back to you on that. Okay. Absolutely.
Okay, that's great. Again, another useful one to pick up detail on.
I will also add that into future reports in terms of that different performance. Thank you.
Great. Thanks very much. Let's take that update as given. I think for me, the thing with the charitable funds thing is we just always need to keep spending it because it's really, really valuable and it enables us to do things that we can't do with our other money. And they can have a really significant impact on not only our patients, but on our staff too. Alison?
Thank you. Yes, that's an important point. Thank you, Paul. I don't think as a trust and our division we've actually promoted enough about what those funds are there and what they're there for, and it relies on hearsay of people knowing that they exist. So I've got it on our work plan to actually promote these out and put it on the intranet in terms of what they are there for and what they can be used for, and do some education and learning around that.
Great, thanks very much. So we'll move on to the reports from the subcommittees. Colleagues, if you'll bear with me to be a little directive on this, can I just suggest that we focus solely on the matters of concern or key risk to escalate box, and we will just take absolutely everything else as read without referencing it, because I do want to make sure we get to some tail end pieces. So in that piece, Nigel, if we could go to the Extraordinary Finance Committee highlight report.
Thanks, Paul. You helped me up there because the item in matters of concern we've already covered in education dormant. So I just would add in terms of the bigger picture that we do have a challenge on capital expenditure this year. We are over committed at the moment to the extent of about 5 million, which we will have to cover by slipping on schemes as a result of overspend on education dormitory, which we covered in yesterday's F&P meeting, which I'll update further the board on in September.
Great, thanks very much. And then Sue from the Audit Committee. It looks like there isn't anything to escalate. That's great, thank you. And then to Trevor, Strategy Committee, similar focus, please.
Yeah, the Strategy Committee, we did have an extensive discussion around sustainability when the strategic plan for sustainability was presented. And it's fair to say not just our trust, but trust-wide and NHS-wide, going from a net zero position by 2040 with the funding that's available is highly unlikely. But I don't think we should treat it as a panic. It's just in the time horizon that we're looking at, we'll end up going slower than the actual opportunity arises. As the opportunity arises, there'll be lack of funding, but I would only put that down as a note, not as a specific issue to worry about.
Right, thanks very much, Trevor. And then Sue, People, Culture, Equality and Inclusion Committee, looks like nothing fresh.
No new concerns, but staffing is always the one that's highest on our agenda.
Yeah, and we've given that a good airing today as well. And then from the Council of Governors meeting, again, the staffing point came out very strongly in the Council of Governors meeting, and actually we've got a session that's been organised for later on today with governors to enable them to learn a little more about some of that. And then Jan, the Commissioning Committee terms of reference are back to us.
Yes, mainly because the Commissioning Committee, Alison and I sat down and looked at the Commissioning Committee, the Finance and Performance Committee and the Strategy and Planning Committee terms of reference, and we just wanted to review them given that we've made those tweaks to ensure that they were all in order. So there's a few minor changes which colleagues can see are in red. And one of those that I think we should highlight as well is the issue about the directly commissioned services and the contract threshold that we've put in there, which is to try and provide some clarity about what goes to commissioning committee compared to what goes to finance and performance committee. Other than that, actually, and we've, sorry, on page 104, we've added in a little bit more clarity on the lead provider arrangements as well, because that's a key part of the commissioning committee role. So I think they're the main changes, and it's really hopefully colleagues are happy with the revised terms of reference.
Thanks. I'll pause just to see if anybody's got any questions on those, but I think that's a really clear introduction for us. Nigel?
Sorry, Jan, do you mean over 250 million? That's
I'm just looking at, I don't think it does actually, Nigel. I was looking at that when I was talking and thinking that doesn't seem right. Can I take that one away? And yeah,
250,000.
Thank you. Yeah, thank you.
Let's make sure that gets noted for the minutes, please.
Yeah, we'll change that on the papers and note that. Thank you, Lauren.
So with that change, can we approve those? Yeah, great, thank you. So just to say, I have got an AOB that I want to pick up, but just before we do that, we want to continue our showcasing of services, which are short videos that have been prepared just to enable us to, in the public domain, showcase some parts of what we do as a trust. Alison, do you want to give a sentence on this one?
Yeah, thank you. Alison Wild, Exec Director of Finance and Estates. So today we're showcasing the facilities team, and I think what I wanted to do is highlight the fact that previously been viewed as a support service, but actually during this presentation they demonstrate that they're an integral part of the multidisciplinary team that are caring for patients, and that really comes across in terms of improving quality and patient experience. And I just think from my point of view, it's a service that consistently delivers and performs in the background, and going through COVID and the things they've done over and above at feeding staff as well as other patients, really proud of them. I will hand over to Mandy Turton, but I just, in John's absence, he was on leave yesterday, and I made an executive decision to leave a photograph in there of John and Mandy when they first met quite a few years ago. So I'll let you watch out for that one during the presentation.
Thanks very much, Alison. So let's take this video, please.
I'm Mandy Turton and I'm the Head of Facilities. So in Facilities Services, we're a trust-wide in-house facilities team. We provide all the sort of support functions to enable good patient care. So we keep environments clean, we feed patients and staff with healthy and nutritious food. And the services that I cover in facilities, we've got patient and retail catering, we've got the patient shops, domestic services and housekeeping, portering, switchboard and reception, patient transport, and we've also got linen and laundry services. The challenges that we've got in facilities is, one of the main challenges is around recruitment. So that's a national challenge in facilities roles. I think partly due to COVID, but also due to pay rates. So we're not as competitive anymore in recruiting to those roles. Other challenges that we've got around patient menu design. So it sounds a very simple task, but trying to balance a patient's menu around diversity and culture, around the special dietary requirements, the food being nutritious and safe and meeting all the hospital food standards. Another challenge that we've got is the patient transport at Brampton. So that's quite a sporadic need, that patient transport, so it's really difficult because it's an unplanned event most of the time to make sure that we balance our resource against that need. I'm really proud to work for this organisation. I'm so passionate about estates and facilities. I'm proud of what our teams do every single day. Actually, estates and facilities have become more widely recognised for what they do, and that service that they provide being an essential service, and not just that support function, but how it links in. I'm really pleased that we've started to get that recognition. I'm also really proud of our retention rates in facilities. We've got a lot of long-standing staff, and I think that speaks volumes. And with those staff, their work ethic and their just sort of let's get on and do attitude, nothing's too much trouble. They'll always do anything that's asked of them in the teams, and they're like little firefighters. I'm just really proud of them. So the plans for the future for facilities, I'd like to see us develop and increase the use of technology in the teams and service. I think we've got a lot of work to do there, and I think that would be more attractive for people to come and work for us if we develop the use of technology, and particularly getting young people into our service. I'd also like to see us grow and develop our integration with other colleagues and services in the trust, and keep that momentum going. Where we've become widely recognised, let's keep that momentum of working together. Our service is a credit to the trust because our performance levels are fantastic. We are not in it to make a profit, we're in it because we care and we want to make a difference, and we want to be part of that patient journey. We're a credit because we also contribute to the health and wellbeing of staff. We keep the building safe, we keep our food safe, we keep the environments that our patients stay safe, and we're also looking for ways to enhance our service and adding value.
Fantastic. That's really excellent.
Please, there were worse pictures that. I think that was I was clinical director, so early 2000s when Mandy got her first level NVQ, and I was presenting her set, and she's now in charge, which is a testament to
fantastic.
And I think these showcase things are working really well. So please do let your teams know as well that these are really valuable for us. So item 23, other urgent business. Just one item, Dr. Bruin. You are our urgent business, and I know we've got you for almost a month yet, but this is the last, as you said, the last public board that you're going to be at, and it's really important that we just take a little bit of time to acknowledge that and reflect on you as well as your time here. So I'm going to start, and it's been an absolute pleasure and privilege for me to work alongside you. All of the theory in governance says that the relationship between a chair and a chief executive is really critical, and it's one that can go incredibly badly sometimes. The joy for me is that I've always felt like you and I have been able to work really closely together, which absolutely doesn't mean we always agree on things. And there are some things we absolutely don't agree on, and that includes some choices of music. But key things for me that you have brought into your time in the trust, and I know have been informed by your journey through the NHS, and I deliberately used the journey word, absolutely, is your patient and staff focus as being really critical. That piece about this is all about us being able to do the very best we can for the people who need us, and to enable those who work for us to be able to deliver that. I think a part of what you bring is a very personal authenticity that is, I know because I hear it from other people all through the organisation, is really valued. You also bring an openness that's an important factor for our governance. And I know you'd never describe yourself as a governance geek, but actually the openness piece is really important, and you've led from the front of being able to say, hand up, you know what, I didn't get that right. And it's not just a we didn't. I've heard you say on occasion, I didn't get that right. And that message that sends culturally is massively important. I think you have driven in particular, you have enabled and driven the equality, diversity and inclusivity agenda. It's one where we know there's a lot more to do, but it's been critically important that you've been there at the front of it. And you've also worked at challenging into the system and really helping our system work and collaborative work and the way we do that. And some of that, a lot of that didn't get seen by other people. I had the privilege of seeing some of it. And I know there are many times when I've thought, actually, I've got a consultant psychiatrist in the room with me. Sometimes I've been the only other person in the room, and I felt that as well, which has sometimes felt really, really helpful. And then my final thing is that I think you've done a great job in enabling executive directors to really be the very best that they can be. So a massive thank you from me. You know I'm going to miss you. You know I wish you really well with family in whatever retirement looks like. So it's been an absolute pleasure working alongside you. And before you get a chance to say anything, I just want to open it up to give other colleagues a chance to speak. Anne-Marie, you've caught my eye. So do you want to start us off?
Yeah, I was also going to struggle to say something because I find it really quite emotional, really, because it's been a, you know, the journey of the word that he hates. And it is an in-joke between the likes of Sue and myself and him, because we used to say journey all the time just because he hated it. So the more we said it, we just, yeah, it was just like that. But it is really difficult. And I suppose from my perspective, it was the fact that he took a leap of faith with somebody like me when he employed me in 2015, and it was a leap of faith because I was an unknown, and I wasn't known to the mental health circuit at all, and I couldn't believe that he just said yes to the job, and so I started, and I just knew straight away that he was an amazing person to work for. And one of the things that I hear all the time is that people know who he is. It's the most incredible thing I've never had a chief exec where everybody knows who he is. You can walk anywhere and they go, oh yes, John Bruin, or yes, and I think, how's he get away around so much? And one of my kind of like little stories is that when after about 3 or 4 weeks in post, he'd sat down and he just said, I just wanted to say thank you very much, he said, and he did all the usual things like he's meant to, you know, thank you so much, and you've done a great job and you've already made an impression. And as I was leaving the room, I said, did you read that in a book? Tell me that. And he just looked at me, and we didn't know each other, and I just couldn't help it. I came out and said, did you read that in a book? And he went, no. I went, oh, that's all right then. And to this day we still talk about it, and we've gone through some fabulous things. We used to do induction together, and I got to hear all his stories. I think the storytelling is amazing. Mm-hmm. I think that's what it really sort of like brings the world into him and staff into him, because he makes it real. And actually, he's quite a clever guy. You'd never realised. It's a really clever guy, but all his stories, you'd think, oh my God, how's he living his life? Yeah, but we've all learned loads, and particularly myself, I've learned absolutely loads from him, and I'm devastated that he's going.
Thanks very much, Anne-Marie. Sue, please.
So I've known John in different guises over the years. So I was interested about some of his stories back in the 90s that I've heard about the tunnels going between the two bits of Mapley, which I'd never heard of, and your days as an SHO scurrying through said tunnels, which I'm sure were always related to patient care. I think that's the important bit to say. Your sense of humour is legendary. Your diary management is well known. I'm glad you said that first. And I remember when you were Associate Medical Director, because I was a new consultant in the Trust, my first encounter was when you were doing the new consultant development programme. And we were all a bit suspicious because, you know, forensic psychiatrists we can be very suspicious about people, particularly mental health psychiatrists, of which he was. So we went to it with a bit of, what's he going to teach us? And we learnt loads actually, and it was really good because I remember then sort of feeling more, you know, watching you go through your career. So then when you were sort of fell into being CEO, we'd all gone a bit of, really? You're going to do that? Because it hadn't been a thing that you inspired quite a few of us to think that. And then becoming your MD. Now, some people will laugh at me for this, but Anne-Maria knows that I think this. If a nurse says you're my doctor or my consultant or you're my nurse director, some people find that really odd, but that means you're owned. So when I became John's MD, we had some interesting times because two doctors working together, you know, it could be challenging. I had to steal his secretary eventually off him in previous trust because he was still doing clinical work. So he had a caseload in Lincolnshire when he worked there. And he's kept trying to keep my secretary to do his clinical work to the point eventually I had to stop it, which was very difficult because you still used to steal her because she kept you in order for all those years as a consultant. And then I think I'd forgotten that I was on the boat in Tokyo when you texted me about this, and I just thought, yeah, absolutely, you know, it's something I want to do. But you let us get on with it. And I think, you know, particularly two doctors working together, I remember a conversation and, you know, that debate about people trying to jump over and come to you, and you were really clear, you know, and you let us get on. But if we need something, you're always there, and you'll have that question. You won't just say, oh, go and do that. So I think, you know, I've developed so much. So I was also, she was emotional. I was just cross when you said you were retired. But you did say you pointed that out to me. You did say that you told everybody. I was like, well, I don't think you did. But anyway, I think you've done so much. You deserve it. I've let go of the anger now, and I can just be nice to you.
Thanks, Sue. Jan.
Sue and Anne-Maria have known John a lot longer than I have. I've only known John a few months, but I just wanted to say, when you talked about leap of faith, Anne-Maria, John took a massive leap of faith on me because I have not worked in the NHS before, was a complete unknown. So I'm eternally grateful to you, John. One of the happiest moments of my life when you rang me up to say I've got the job. So that was absolutely fabulous. And on my second day in the trust, we had our previous board meeting in public, and I sat there and I heard John's sense of humour, which I love, and the way he handled everything. And I thought, gosh, I'm so glad I'm working for him. That's brilliant. And the next day, I got an all-staff email to say that John was retiring. So I was also upset. I don't have that long-standing relationship, but I was very upset. But actually, having the opportunity to work with you for these few months has been brilliant because it's really helped me, I think, get established, set me on a path. And I would echo what other colleagues have said about being on hand to help, but also letting us get on with things and empowering us and giving us the confidence to do so. So I'm very grateful for that, John.
And Alison, and then I'll give you a chance just to speak
Thank
yourself,
you.
John.
So I did know about John's retirement probably before anybody else because I could help him sort the pensioner. But like everybody else, really gutted when you said you were going. Really enjoy working with you. It's just not been long enough, really. And I've got to say, it's thanks to you that I'm actually sat here today because you gave me that support and encouragement and persuaded me I could actually do it. And without you having done that, I don't think I would be sat here today. But I just wanted to share with the board the little bit of advice that John gave me when I was first acting into the role. Sit back and do nothing and the money will sort itself out in the end.
It's going well.
No defect. Sit there long enough and it will sort. But yeah, thank you, John. I really appreciate your support.
Great, thanks, colleagues. And just to say, obviously, I know that we'll still have more times to say goodbye to John. But John, I just want to give you a chance just to reflect, rebut whatever you need to do from those comments and everything else.
You know, Alison's absolutely true. So right, I did say that to her. But fortunately, she didn't listen to me. No, thank you, everybody, for those kind words. I'm not really prepared to know what to say other than I will miss it all dreadfully.
I've been in the NHS since 1981, and some guise or another, which seems like a lifetime away. I was, some of you will know this, regarding myself as a fairly accidental chief executive. It was never part of the plan, and being a doctor was never part of the plan. I didn't have the gumption to split with my girlfriend when I was 17, who was desperate to become a doctor and go to medical school, and I didn't have the heart. So I applied to medical school as well, just not the same one. I thought I probably wanted to be a psychiatrist, but I loved A&E, and I almost became an ED doctor. But I did psychiatry in the old asylums in Leicester. I never really had a grand plan to be a medical director, but I saw the job and I did it. And I certainly didn't have a plan to become chief executive. That was a very tragic circumstance in Lincolnshire, where the then chief executive sadly suffered a life-ending stroke, and I was sort of pushed into the role. And that was nearly 10 years ago now. I'm really concerned about where the NHS is, as I know everybody is, and I'm sad to be leaving it at a time of I think probably its greatest peril. I'm heartened though by, we've got over 9,500 staff and volunteers in this organisation who I know will do their utmost to adhere to the principles of the NHS, and why we're also dedicated to working there. So that does give me some heart and confidence. I have loved working with you all. The executive team, you have your own lionesses. And I've thoroughly enjoyed working with you all, some for longer periods, some for shorter periods, but I know that I leave it in extremely good shape, with huge potential to brilliant things for the future. I'm sure we'll have time for further conversations, but my advice will be bold. This is a time for huge opportunity. Try not to get too risk averse. This organisation is in a superb position, given what we do and where we do it within the system, to continue to do great things. And more broadly to the board, there's always, rightly, isn't there, tension within the board, and the role of the exec, the role of the non-execs. But I think with your leadership, Paul, we're working to a place where the board is increasingly on top of its game, becoming more collective in its endeavour, more strategic in its approach. And again, I'm so pleased to be leaving it in good stead, and I know that my interim and permanent successors will continue to do that. And then more broadly in the room, there's lots of people, as we've heard from today, that whether we call them corporate or support or part of the MDT, are huge, strong foundations for us to do what we do. And so thank you to you all for enabling me to do what I've done over the years I've been here. So I'll miss you all, and thank you very much.
Thank you. Okay, I'm going to propose, folks, that we do our review piece after the part 2, rather than now. So just to wrap up, thanks to a few people. Chris, thanks for stepping in again to ensure that we've got support in Julie's place. Much appreciated. And loads of people been working behind the scenes. So Grace, Lauren, Dawn, Jenny, Roshane, Rebecca, Suzanne, thanks to you all for your contributions, and a shout out to Martin on the tech, which has gone really well, especially given we've been hybrid. Colleagues, I'm going to suggest we restart at 1:30. just because we need to get through our lunch. So I hope that works for Sue and Fiona as well. So thanks very much everybody who's been watching, and indeed colleagues who've been in the room observing us as well. And we'll restart at 1:30 for part 2. Thank you.
Fiona, do you think we're using the same link? Should we just keep this open?
I think it's a different link. I've just emailed, hold on, I've just emailed the team. Bear with me, Sue, because I just emailed the team.
Because I haven't got another link.
Are we still recording or are we still live?
We're still live, but I don't think I'll matter for what we're talking about. Oh, it'd be on a separate link.
It should be a separate link. I'm going to send it to you, so I've just asked for it.
Thanks.